Now let's start with the opening session with welcome remarks from our hosts, the National Institute of Malariology, Parasitology and Entomology, also in short NIMPE, from Vietnam, followed by remarks from APMEN. So our first speaker today is Professor Dong, Director of the National Institute of the NIMPE in Vietnam. And Vietnam, as you all know, is also our host. So Professor Dong has worked for many years in the Ministry of Health in Vietnam on the control of infectious diseases, including scientific research on malaria and parasitic diseases. He is also responsible for overseeing the Global Fund supported Regional Artemisinin Initiative, or the RAI program in Vietnam, and is also an associate professor and doctor of medicine with teaching positions in 2 medical universities. He's an active participant in collaborative activities with many organizations, as you can see on the slide WHO, APMEN, ACT, Global Fund, APMEN, and also the US CDC. So I will hand over to Professor Dong. Over to you. So I don't hear Professor Dong yet. Professor Dong, are you there? So it seems that he's not online yet. He might have a technical problem. Yeah. Professor Dong?
Yes.
Ah, wonderful. Professor Dong.
Good afternoon, distinguished leader, ladies and gentlemen. Warmly welcome to APMEN country partner, represented from officials from the 22 national malaria program across Asia and the Pacific, representatives from APMEN partner institutions, including implementing partner, academic and research institutes, civil society organization, university, community-based organization, and the private sector. Vietnam's progress toward malaria elimination. The government of Vietnam remains committed to the 2030 goal of the eliminating malaria from Asia and the Pacific. Vietnam has seen an almost 90% decline in malaria cases since 2010. Is now part due to the availability of the essential malaria commodities, particularly long-lasting essential in high-risk populations. In addition, the utilization and appropriate diagnostic has reduced in the likelihood in misdiagnosis and inappropriate treatment and antibiotics. The threat we face with artemisinin resistance developing more broadly in the greater Mekong sub-region has been reduced to a great extent through coordinated with action with national malaria program in the region through the regional artemisinin initiative RAI. The RAI is now entering its third phase. We need to accelerate effort to eliminate falciparum malaria by 2025. A set to radical cure for the relapsing malaria virus is critical as 36% of the confirmed cases in Vietnam are now due to virus. APMEN annually meeting and Malaria Week 2020. Vietnam has experienced significant gain toward malaria elimination over the last 10 years. This has been made possible due to the resonant platform like APMEN that allow for the coordination, sharing of information, and the best practices, and providing access to native development and innovation, whether the related to the vector control or radical cure for the virus. Vietnam has been a member of APMEN since 2012 and collaborates with the network through the 3 working groups. The APMA dashboard is important tool for the government officials and partners to check progress in the region toward elimination. The technical annex of the dashboard provides a snapshot of progress with data from the One Malaria report and support Malaria program manager with information on the key priority in terms of high burden area and help to inform decision making by the National Malaria Program. The next 10 years will require strong multi-sectoral partnership that includes strong engagement with the private sector and community-based organizations. We are glad to see this year the APMEN annual meeting is focused on the exploring alternative model of the engagement with private providers and CSOs. The APMEN platform provides an opportunity to share the country experiences and support country-to-country collaboration, especially in reaching the hard-to-reach population. Our experience with COVID over the last 6 months has highlighted the importance of the partnership between the public sector and private sector and civil society. We have seen the strong role played with the community health workers and private providers in creating awareness around COVID, as well as in ensuring access to malaria services for the most vulnerable. The government of Vietnam and NIMPI are pleased to host Malaria Week 2020 and the APMEN annual meeting. This year, the APMEN annual meeting provides us an opportunity to reflect on the year gone past, review our progress, identify key challenges, share the best practices, and highlight specific issues for action at the APMA senior official meeting. Why is it unfortunate that we cannot able together in Hanoi this year? The virtual meeting platform allows us to continue our important discussion. I hope that during today's discussion, we can identify priority action that we need to take forward nationally and regionally to keep malaria elimination on track. It's my honor to welcome government officials from National Malaria Program. Productive meeting. Thank you very much.
Thank you very much, Professor Zong, for that warm welcome to Malaria Week 2020 and for your perspective on the role of APMEN and its contribution to malaria elimination in the region, and of course, the contribution of Vietnam to this network. So I would like now introduce Professor Tiki Pangetsu, the chair of the APMEN Board of Directors. And Professor Tiki Pang is an academic and expert on arboviruses and other tropical diseases. He holds a PhD in immunology from ANU and is a visiting professor at the Yong Lo Lin School of Medicine at the National University of Singapore. And he also served as a policy director for research policy and cooperation at the World Health Organization in Geneva. So I invite Professor Tiki Pang to share perspectives on progress made towards elimination and challenges and opportunities presented by COVID-19. Over to you, Professor Pang.
Thank you very much, Jost, and hello to everyone, wherever you are. Let me begin by thanking, first of all, Dr. Dong, NIMPE, and the government of Vietnam for hosting the APMEN annual meeting, Malaria Week, and the senior officials meeting later. We are most grateful for your generosity in hosting this whole week. Let me begin by highlighting the fact that, before the COVID pandemic, we have sort of really made good progress in terms of malaria elimination. Dr. Dong, you highlighted how successful Vietnam has been At the same time, we have seen no cases in malaria and Timor-Leste, and no deaths in Cambodia. And that good progress has been due to efforts around surveillance, around access to diagnostics, to treatment and prevention tools, and also supported by resources that has been available for all these activities. But at the heart of it really is that this success is due to the countries taking ownership and providing leadership towards malaria elimination. And then, of course, against this background of success, we had COVID hitting us at the beginning of this year, essentially. And I would like to think of COVID not just as a totally negative event. Yes, of course, because of COVID, we have seen a surge, an increase in cases of malaria, not just malaria. Dengue is another example. TB is another example. A drop in childhood vaccination is another example because health systems have been preoccupied with dealing with COVID. But at the same time, it also serves to highlight why the health system as a whole is so important. It has to be able to deal not just with malaria, but with so many other diseases. And in this context, also, COVID has also highlighted inequities because there are parts of the population which are disproportionately affected by COVID. The vulnerable, the marginalized, and parts of the population who are unable to access healthcare because of the distraction of COVID. So that brings me quickly just to highlight in this context, what might be the challenges in the future for APMEN and its partners to continue this very good progress. Very importantly, once again, because of the importance of health system, the first challenge is to continue to work towards integrated service delivery, to innovate around integrated service delivery in the context of the health system as a whole. And importantly, to also involve the frontline health workers, because COVID has actually told us that the role of the community in terms of surveillance, for example, they are the best people to actually alert you when something is going on. So in a way, we could learn from that as a result of COVID. So the role of volunteer malaria workers in Myanmar, for example, is another good example, which in the future, APMEN will try to perhaps expand to other countries in the region. And finally, as Dr. Dong has mentioned, COVID has also highlighted the importance of the private sector. Okay, it's undeniable that in the COVID response, the private sector has been very central, not just in developing of vaccines, but in developing of treatments as well as rapid diagnostic tests, which, as we know, is central to the malaria elimination effort. So against that background, the annual meeting of APMEN this year will particularly focus on two of those dimensions and challenges that I mentioned. First is how do we work towards better private sector engagement? And secondly, how do we integrate in the future this bottom-up approach, community-based approaches, bottom-up to complement perhaps something which is at a higher level, advocacy, political advocacy that APMEN is doing. So in that sense, that's going to be the focus of the annual meeting of APMEN. And basically, it sort of allows me to highlight the important transition that's going on between APMEN and APMEN. I think in the future, we hope to see further integration, closer connections between APMEN and APMEN, top-down, bottom-up, if you like, and also to make the country work more intentional and more targeted towards engaging and taking into account the priority of the countries themselves. So to embrace integration more closely and to engage more closely with the countries. And finally, also to put into all this a more holistic approach in the two organizations working together, making better links between the technical operational issues that Joost and Dr. Dong has mentioned, together with the policy issues at the higher level of government. So I'll stop there, and just to say that I look forward to hearing during this annual meeting from APMEN's partners on their views, and also once again to really thank them as critical partners for APMEN and APLMA in our efforts to eliminate malaria by 2030. Thank you very much, Joost.
Thank you very much, Professor Pang, for your rich insight into the role of health system strengthening and what it means for malaria elimination, also referring it to the COVID context these days. And I would like now to introduce Dr. Satak Das, the CEO at the Asia Pacific Leaders Malaria Alliance. Dr. Das just recently joined APLMA in May 2020 from the Harvard T.H. Chan School of Public Health, where he holds appointments as a research scientist in both the Dean's Office and the Departments of Health Policy and Management. And he's also a senior advisor for research translation and global health policy at the Harvard Global Health Institute. Dr. Das has over 20 years experience as both a public health scientist and a development practitioner. So Dr. Das, please share your perspective on country engagement for improved health and malaria outcomes. The floor is yours.
Thank you. Thank you very much, Professor Zung and the colleagues in Nimpay and the government of Vietnam, and to Professor Pangestu for the opening remarks, and to Joost for already helping us have a smooth presentation so far. I did have some slides, so I'm not sure if we could pull those up, but while we're waiting for that to happen, I really want to thank the Amita Chabi and the team at APLMA and APMEN for welcoming me so far into the work of APMEN, and in particular to inviting me to speak at this event. You know, I think that in my understanding of the history, APMEN predates APLMA. And I think I've been thinking a lot about what that means, and I'll come back to this as a metaphor repeatedly in these remarks, but it's the foundation as far as what I can understand about what needs to happen regionally in terms of malaria elimination, and obviously at a country level, because it produces the evidence, it links the science, and it builds capacity. And so it is very much the foundation on which APLMA relies. And the notion that we can separate these two is really an impossible one. If we could just go to the next slide, please. My presentation is really just three simple areas. And first is really around background. I'm not going to say anything about my own background, actually, because you've already done that. But I did want to say this to further the point around background, that it is not only about the generation of evidence as being the foundation, but ensuring that locally generated evidence serves as a means to build local capacity. And so if we could fast forward to the next slide, and just to add a bit more color, and to many of those who may be wondering, why is someone from HIV and TB now in charge of the APLMA Secretariat? And really, the heart of my experience, I think, putting a vertical disease aside, is to Professor Pangestu's point, coming out and born out of living, for the most part, in the field over the last many years. And if there's anything that has taught me, is that one, ultimately, we have to allow the public sector and countries to lead us. Two, we have to make sure that when we think about vertical interventions, they're always thinking synergistically about how we can use what's on the ground. And three, there really is, no point to such endeavor if it is not always oriented to a point of view that is building capacity, and certainly thinking about building capacity subnationally. Could you please forward to the next slide? So when I think about foundational principles for APLMA, I think I would suggest to the network, or offer to the network, to consider these from our perspective, because in the documents that I've read and what I've been learning about APMEN, these very much seem to be ingrained in the network's philosophy. But certainly foundational principles from my perspective in regards to what this platform offers are around ensuring that all the work is country-owned and country-led, ensuring that the kind of research that happens really prioritizes research of an operational nature that always is linked to capacity building. And as I mentioned, work, because we are dealing in malaria elimination, certainly in a context where most of what we have in terms of areas of higher prevalence and incidence is among those last pockets, among the vulnerable, among to rural people and remote populations, be they people moving in between forests and borders in the greater Mekong, or people living on the islands in Papua New Guinea, or people living in tribal communities in India. I think that there is no path to elimination, as all of you know better than I do, that is the path where we must put an intensive focus to be able to accomplish what needs to be done. And the fourth point is something I'd like to describe a bit more in the next slide, please, because I wanted to speak a bit to, if we could advance to the next slide, how do we actually work together? And so understanding that the foundation of APLMA is APMEN, is data, is evidence. With that in mind, and thinking about how do we work together? How do we do this? I see this really as 4 pillars and a framework for action for APLMA and APMEN together that includes and begins with the generation of local evidence. And really that's the starting point of a continuum that then moves to taking that local evidence, ensuring that it is appropriately socialized, understood by everyone, beginning with country leadership and WHO and other normative guidance of all the other important partners, to be able to then advocate for policies that will result in the necessary resources. But that work for us as APLMA has to really begin in the middle and end with country engagement. There's no way that we can do that in the absence. And yes, we are a regional platform, but to be a regional platform that is viable and can be speaking with credibility and trust within specific countries, there is no other way than for us to build our relationship with countries. And that is through the vital partnerships that this network offers. Next slide, please. So to be specific in regards to COVID, because I don't think it's possible for me to not address this, I think as Professor Pangestu has suggested, rather than seeing this as only a crisis, it certainly provides us with a lot to think about and gives us opportunities in terms of really putting our technical skills, our partnerships together in a way that can serve a dual purpose. Many groups, obviously, including WHO, are leading excellent work around this. So I would say in terms of country engagement, how APLMA and APMEN can work together is not only through the core working groups that currently exist that are critical to the elimination agenda, but to also remain aware, attuned, and attentive to the fact that all these national programs are contending with something that is not going away anytime soon. And so in what ways, what specific ways might we be able to think about a more dynamic, synergistic approach? And these are just some of the ideas that are out there. But I do think in regards to regional level modeling, in surveillance, leveraging new diagnostic tools, in particular, those three, where I see APMEN, APMEN playing a role together is, again, being able to take platforms, convenings, but link them to specific purpose. So it's convening with a purpose, it's platform with a purpose to try and answer specific country needs, see where we can help move the needle around a particular validation or sensitize leaders to some type of modeling work and so forth. In terms of number 4, I think it's critical also for us all to continually push the agenda around program management and building program management capacity, particularly at the subnational level, as a major priority. Because again, as I think the community at large knows, without strengthening program management, we will not be able to sustain the gains made in elimination. And I think many countries, including Sri Lanka, for example, have proven that, or are proving that when you do that, you are able to have a successful response to COVID. And the last point is one that was already spoken to, but again, I think we need to spend a lot of intentional time working together in thinking about that cadre of health worker, that is village health workers and community health workers who have been significantly deployed in national malaria responses. And the only other thing I would add is that we need to be thinking of them always as part of a system, because where that focus can sometimes go wrong is when we don't think of them as part of a referral pathway, which then results in it becoming another siloed layer of the health system. And so moving to the last slide very quickly, I just wanted to, actually, this is not the last slide. The last slide, yes, just very quickly, thank you. Wanted to close by saying, I do think that this provides us with an unprecedented opportunity, that is the pandemic, to really think about what we mean when we say capacity building and to build a new paradigm for capacity building. Because we're no longer in an era where we're going to be, at least we're not in a time at the moment where we're all sitting together around a table in a convention hall. And I think in the years to come, this could enable us new ways of thinking about how we build capacities that are those kinds of bridges that are made out of roots that will stay over time. So thank you very much for welcoming into your community, and I'm looking forward to the day's session.
Thank you very much, Dr. Das. And thank you to actually all the speakers for setting the context for the APMEN annual meeting and providing a framework for the 2 sessions we have lined up for you today. We will now move into our first working session for the day on private sector engagement for malaria elimination. Just one sentence again about the mechanics, because many people have just recently joined. So I want to remind you all maybe to use the speaker view. That will give you the best experience. So you will see actually the speaker in a large screen. And also please make heavy use of the chat box. We like to hear your comments, your thoughts, and you just write them in the chat. And I have seen some wonderful discussions going on in the chat box. So please share and do not hold back. So now I have the pleasure to actually introduce you to your chair and moderator for the first session. Her name is Sandy Lewin. She's no stranger to many of you. She's an international public health specialist and has worked for more than 20 years across 6 regions. She founded the Myanmar Health and Development Consortium in 2012, and she's also serving as a senior health advisor to APMEN. Formerly, she worked for the Global Fund, World Bank, UNDP, and many other international organizations like the IMF and the National Network of Asian and Pacific Women. So I hand over to Sandy Wynn and I'm looking forward to very interesting discussions because we have an excellent panel. Sandy, over to you.
Thank you very much, Josh, for the warm introduction, and a very warm welcome to all the participants to this session, where we'll have APMEN country partners share their experiences with private provider engagement. The presentation will then be followed by a panel discussion. A key objective of this session is to share recommendations for policy processes at the APMEN Senior Officials Meeting which is scheduled for Friday, September 11th, and we very much welcome your feedback. Due to time constraints, as Jos has mentioned before, we may not be able to have a Q&A session today, but we encourage you to use the chat box below so you can share your comments and feedback. Over the years, private sector engagement has been identified as a critical area by APMEN partners as we journey towards malaria elimination. In most parts of Southeast Asia, private providers are often a major, if not a primary source of provision of healthcare, including for management of febrile cases, also related to malaria. For the purpose of this discussion, the private sector is defined as any facility, outlet, or individual offering health information, products, or services that is not managed by the government. One of the objectives of this session is to provide a platform for the national malaria programs to share information and exchange experiences with private sector engagement from their own country contexts. We will start the session off with country presentation from Indonesia, followed by Myanmar, and we'll see whether Afghanistan can join us. We will begin with the presentation from Indonesia and I would like to introduce you to Dr. Didik Budijanto. Dr. Budijanto is the Director of Prevention and Control of Vector-Borne and Zoonotic Diseases at the Ministry of Health in Indonesia. Previously, he served as the head of the Center of Data and Information at the Ministry of Health. And he also graduated from Faculty of Veterinary Medicine and got his master's in public health and PhD in public health from Airlangga University in Surabaya. Without further ado, Pak Didik, please proceed with your presentation.
Thank you, Sandy. Yeah. Good afternoon, ladies and gentlemen. It's an honor for us from Indonesia to share our experience in public-private mix in Indonesia and the role of industry association towards malaria elimination. First of all, let me wish you all of to be always in a good health during this COVID-19 pandemic. Ladies and gentlemen, this is malaria. I think I would like to have Dr. Helen to share. Yes, this is malaria situation in Indonesia. Out of 514 districts, 16% have received a malaria elimination. Currently, there are 23 districts, 4%, which are still high endemic area. The endemicity of malaria shown on this slide is low, medium, and high endemicity, respectively indicated by the color difference, namely green, yellow, and red. And you can see that the colorlessness are malaria-free areas, and currently 79.9% of Indonesian population left this area, they are already malaria-free. Next. This slide shows that the challenge faced in malaria control in Indonesia today. There is stagnation in detection of malaria cases, decrease in cases caused by the COVID-19 pandemic. The graph of left shows there's decline in malaria cases from years to years, which all actually decrease the majority of cases outside the Papua province. However, there was twofold increase in case detection in the Papua region based on the annual blood examination rate, ABER. With this increase in case detection, case reported in Papua also increased. In 2019, 86% of cases in Indonesia were reported from Papua province. The graph on the right shows a decrease in case finding or more than 15% compared to this case to the case finding that in January until June 2020 due to large-scale social distancing during the COVID-19 pandemic. During the COVID-19 pandemic, several adjustments were made so that mitigation activity can continue with the implementation of health protocol. With the circular from the Directorate General regarding protocol that must be carried out as a reference in carrying out prevention and control activity of the malaria program during the pandemic period. The protocol on malaria prevention and control during COVID-19 pandemic issued by Director General of Disease Prevention and Control on 23 April 2020, which includes the first adjustment of COVID-19 screening flow in malaria endemic area to include malaria screening. And then adjustment of malaria service in the health facility to use RGT to reduce crowd, and adjustment of epidemiological investigation by health staff and active case finding by community health worker to use PPA during field and home visit. Adjustment of LLIN campaign to limit crowd in distribution point by 10% maximum, or conduct the LLIN campaign through door-to-door distribution. I think next, yeah, slide. The slide shows that national plan, yeah. The national plan, action plan for acceleration, yes, of malaria elimination 2020 until 2024, highlight the importance of private sector and engagement in all four strategies. We have four strategies: territorial, yeah, and the yes, I continued. Yeah, the second increased its number of malaria-free districts from 285 in 2018 to 405 by end 2024. The third, malaria-free status in maintained is district which have been awarded malaria-free certification additionally. There are four strategies with one, universal access for the malaria case management and prevention. The second, surveillance, score intervention of malaria elimination. And the third, improve enabling environment to ensure malaria elimination achievement, including through PCC and community engagement. And the fourth, strengthening the health system to deliver malaria elimination program. That's a public-private mix is a component in all strategies. Next. In Indonesia, this public-private partnership has been going on for a long time in the region. The slides show best practice in the form of partnership on malaria control program with British Petroleum in Bintuni District, West Papua. This is the best practice one. Yeah. The malaria team of British Petroleum integrate with the malaria team of district head office and together strengthen the case management. The process was carried out. The pharmacy and transit ACT, a malaria medicine, to be given to the community or cadres with an introduction from a doctor and a result from a malaria blood test. and an activities case finding was carried out as well by cadres. As a result of this collaboration, the API decreased from 114.9 per mil in 2006 to 5.5 per mil in 2012 and even to 26 in 2016. This program received a public service award from the United Nations in 2018. As a good practice second, next, yeah. The slide describes the partnership with the Sumba Foundation in Sumba Region, the East Nusa Tenggara Province. The Sumba Foundation built a microscopic training center. The training carried out was basic malaria microscopic training was held for 2 weeks. This was a collaboration between province and district health office with the Association of Indonesian Medical Laboratory Technology expert in the province. Yeah. Next. The third best practice, another sample of good practice that can be lesson learned in the partnership of the malaria control program with the private sector in Manowari, West Papua for quality assurance and standard treatment. You can see the flow of government-private partnership service on the left, and the right slide show the signing of the MOU between the head office and private pharmacies that can provide malaria drugs according to standard. And the evaluation of partnership, next, with a private pharmacy in the Manowari district, West Papua. The following is an evaluation of the best practice carried out in Manowari in the previous slide. In the evaluation of government partnership with private pharmacy in Manowari Regency, West Papua Province, it can be seen that an increase in services for malaria patients, existing malaria drug and private pharmacies in 2019 compared to 2018. Although there has been a slight decrease in the number of private pharmacies involved. As a lesson learned, next, yeah. Ladies and gentlemen, based on this practice base, we can conclude that the private sector is a potential partner in achieving malaria elimination and should be involved in a call, killing, intervention in all phases of malaria elimination, from acceleration, case reduction, to maintaining malaria elimination, benefiting from this public-private partnership. And the second, partnership can work well if the private sector is closely involved with province and district head office, and all cases are reported in the malaria information system, which accommodate private service reporting. And the third, public-private partnership network in the management of quality malaria cases. The private sector is given free ACT drug and participate in the capacity building of resources carried out by the government. With regard to gap and opportunity in malaria control program in Indonesia, the point are the first one, Indonesia has a large area. Therefore, the management of private sector still heavily driven by local initiative. And more systematic management will be orchestrated by the Ministry of Health at central level to support the initiative in a local level. The second is, Indonesia is applying decentralized governance system. The success of partnership depends on the leadership and arrangement at the strict level to the governance system, the success of partnership. These practices have been demonstrated effort to studies and evaluation support by practice is still limited. I think let me conclude my talk by thanking you all for your kind attention. Thank you very much.
Thank you for the very interesting presentation on private-public mix for malaria in Indonesia, Pak. Our next presentation today is from Myanmar. I would like to introduce Dr. Wimpyotha, Deputy Director from the VVDC program in Myanmar. Dr. Wimpyotha received her MBBS degree from Institute of Medicine 2 in Yangon in 2004 and completed her MPH from University of Public Health in 2013. She also studied International Field Epidemiology Training Program in Thailand from 2016 to 2018. She has over 11 years of experience working in the field of malaria. She is now serving as Deputy Director, VBCC, Department of Public Health in Ministry of Health and Sports in Myanmar. May I now present Dr. Wimpyotha.
Good afternoon, everyone. I am Dr. Wimpyotha from Myanmar, and on behalf of Myanmar NNC National Malaria Control Program, thank you very much, APMEN, for providing an opportunity to show Myanmar case story on engagement or private sector engagement in malaria. I will capture the engagement in few slides. Next slide, please. Myanmar is the second largest country in Southeast Asia with about 52 million population residing in 15 states and regions that comprise 330 townships. The country is bordering with Bangladesh, China, India, Laos, BDR, and Thailand. Out of total 52 million population, 22.3 million population are at risk of malaria. 53,000 cases and 14 malaria deaths were reported in 2019. 60% of malaria cases was Plasmodium virus in 2019. Primary vectors are Anopheles direct and Anopheles minimax. The slide shows the trend of malaria case and death during 2005 to June 2020. The decline in case and death are striking. Next slide, please. In 2019, next slide. In 2019, Myanmar reduced 89% malaria cases and 97% malaria deaths in comparison to 2012. The success factors are huge network or 21,000 frontline health workers and private outlets, wider coverage of long-lasting insecticide treatedness, quality sure diagnostic, microscopy, as well as RTT and anti-malarials. National program was able to provide equitable malaria service that have reached to all parts of the country and cover risk population like forest goer and mobile and migrant population. Malaria services are being provided by over 30 partners, which also include the private sector. Last but not the least, funds were available to carry out program activities. Thanks you to the generous donor and also to technical assistance of WHO. And next, please. The timeline for malaria elimination is 2030, and Plasmodium falciparum elimination target is by 2025. The private sector is crucial to fight malaria and achieve these targets. With this in mind, Myanmar has developed private sector engagement guidelines to guide the sector for national malaria response. Next, please. 65% of malaria cases in Myanmar are reported through private sector. Of these, 54% seek care from the private sector. There are over 80,000 medical doctors work as private practitioner during 2013 to 2014. This number have grown in recent years. As shown in the slide, private sector in Myanmar is comprised of general practitioner, hospitals, non-health sector, etc. There are numerous projects operated by private sector like artemisinin monotherapy replacement and M2030, which bring business, consumers, and organizations to defeat malaria. Next, please. The slide shows the contribution of private sector in different areas. In 2019, 1,400 trained private providers conducted 236,000 tests and detected 2,300 cases. These practitioners notified 522 cases to National Malaria Control Program. The private providers are also supported in removal of oral artemisinin monotherapy from the market. In 2019, the availability of oral artemisinin monotherapy was 5% in comparison to 67% in 2012. Private sector are also supporting National Malaria Control Program in LLIN distribution. Moreover, private sector are also engaged in generating evidence for effectiveness of insecticide-free clothing and repellent, which will be important to address outdoor malaria transmission. Next slide, please. This slide shows the National Malaria Control Program's malaria data flow by types of providers. The malaria volunteers enter the NNCP and partner, and the private providers need to mandatorily submit malaria report to the designated focal point of healthcare facility. Then the data flow to the central level through the dedicated channel. I would like to draw your attention to the black box where the data flow within the private provider are highlighted. The data is linked to the National Malaria Surveillance System at various levels as shown by the blue solid line and dashed green line. Now we are using paper-based reporting up to the township level. At the township level, the data is entered via the computerized system and sent to the NNCP server. The data from this server can be accessed by township, state and region, and central levels. We would like to mention that National Malaria Control Program has developed a web-based reporting system. This system will provide access to the private provider to submit data through the web-based system. And next slide, please. I would like to cite a specific example of one of the projects SMS for Life undertaken by UMFCCI Myanmar jointly with National Malaria Control Program. The objective of this project is to engage non-health private sector to support malaria control and elimination. More specifically, to develop comprehensive corporate sector engagement strategy, implement public-private partnership activity, use innovative technologies and expertise to the private sector, and engage private sector business to become active partner in malaria elimination and promote CSR. Mobile for malaria component introduced award-winning SMS for Life platform, which is shown in the slide. This is used for timely reporting of case investigation, case management, and stock management situation at MOHS facility. Deployment of ICME and website volunteer level. Integrate with fast-moving consumer goods, delivery component for transport of essential supply to MOHS facility. The project worked with volunteer, website, and real health center. The data on case and commodity generated by these channels are transmitted to the cloud server. The data from the cloud can then be accessed by the basic health staff, township health department, as well as the central level. And next slide, please. This challenge and way forward, there is a optimal engagement of private sector in malaria fight in Myanmar. The program has vision to expand the private sector network to include 100% of the provider in years to come. This will include both health and non-health sector. However, the challenge of financial and human resource to engage this sector will remain. Moreover, some of the high malaria burden are still present in non-government control area, and there will be operational difficulty to reach to this private sector. Program will work with ethnic health organizations in this area. It is equally important to regulate these private sectors. Finally, I would like to mention that National Malaria Control Program will work with WHO and partners to fully implement the private sector engagement guideline. We will work together with private sector to achieve malaria elimination. And next, please. We acknowledge the generous contribution of private sector in the fight to end malaria in Myanmar. We look forward to stronger collaboration in days to come. Thank you very much for your kind attention.
Thank you for the very interesting presentation on private sector engagement, Dr. Wimpyo. I think the two country presentations have provided a good context for our upcoming panel discussion. As we've heard from our government representatives, there are various approaches to engaging with the private providers. Having said this, I think we could do a lot more. This is particularly critical for the Asia-Pacific region. In order to achieve elimination, countries need to manage and report all malaria cases, which requires engaging the private sector, and particularly where the private sector is already providing a significant proportion of the healthcare. In this panel discussion, we'll be highlighting some of the experiences from implementing partners, share information on the kind of support available from partners to NMCPs to develop private sector engagement plans, learn from other diseases such as tuberculosis, as well as other peer-to-peer collaboration models from our partners in Africa. So without further ado, I would like to start this session by introducing our panelists. We're honored to welcome our colleague from Zambia, Dr. Mutenda, Acting Director of the National Malaria Elimination Center in Zambia. Dr. Mutenda joined the malaria program 6 years ago and has a rich experience of working in Zambia. Our second panelist is Dr. Kemi Tesfagi. Dr. Tesfagi works with Population Services International as a program director of Gates-funded GEMS program. In her current role, she provides leadership to ensure that the program objectives of transitioning private sector network oversights to NMPs is achieved while ensuring high-quality, evidence-based implementation and documentation of all technical aspects of the program. We also have with us Dr. Badri Thapa, malaria scientist with the WHO Country Office in Myanmar. He works very closely with the Myanmar National Malaria Control Program in support of their malaria elimination goal. Finally, we have Mr. Anna Pal. Mr. Pal is a senior manager at Clinton Health Access Initiative, or CHAI, leading some of the tuberculosis private sector engagement projects in India. We just heard from Dr. Wimpyo on the experience in Myanmar. So building on that presentation, my first question is directed to Dr. Badri Thapa from WHO. Dr. Badri, WHO plays a critical role through its country offices to support the national government in developing appropriate health policies and guidelines. Can you share your experience with supporting the NMCP in Myanmar with developing private sector engagement guidelines? What do you think were the critical areas of support that you were able to provide? And can you walk us through the steps involved in developing and finalizing national private sector engagement plans?
Thank you, Dr. Sandy, and thank you, APMEN, for providing this opportunity. And also, it's good to be here to support and complement Dr. Wimpyo from NMCP. She already highlighted some of the engagement in the private sectors in Myanmar. And she also mentioned the target for malaria elimination is by 2030 and PF target is by 2025. And this is also based on the numerous targets that we have with us. And WHO's main support to NMCP is setting the malaria policies and strategies, and importantly, developing important documents that support implementation of these strategies and policies. And private sectors, as mentioned by Professor Tiki and by Dr. Das, and also in Dr. Winfrey Than's slides, we are clear that they play important role in the malaria fight in the country and also in Myanmar. And she also clearly mentioned that 54% of the febrile illness access service to the private providers. And now National Malaria Control Program is making malaria notifiable disease. So this means that all private sectors need to mandatorily notify to the health authorities. And even the zero reports need to be submitted to achieve elimination. And with this background in mind, it is important to have a private sector guideline in place that will guide the private providers to help the NMCP to fight malaria in Myanmar. And as Dr. Sandy asked me to go through the step-by-step process, I will enumerate few steps now. So it was in the country, it is very important to buy the process, buy in the NMCP's they need to be in to develop this guideline, and NMCP was engaged and they had a good leadership and also saw the ownership of this development process, and they were fully engaged and steered to the entire process of this development of the guideline. And Dr. Win already mentioned that private sectors are engaged in numerous activities, and we didn't start from scratch. We just built on the existing experiences. And we know that there are a lot of private partners working with the private sectors. And one of the important partners is Population Service International. So WHO and program jointly engaged PSI to engage over 400 private providers on the malaria test, trick and track services. And these projects include mapping of the service providers and developing inventories and select private providers based on the set criterias and also based on their consent. And we had an assessment, baseline assessment on their knowledge, attitude and practice on malaria. And training curriculums were developed based on those and trainings were provided. And finally, they implement a set of activities that was supposed to be a part of the guideline. And after implementing this project, so the draft guideline was developed that was comprehensive enough, outlining the steps for the engagement, and also include number of tools that would be required by the local health authorities and also by the partners. And after the draft was ready, so the draft was consulted in a larger forum with the expert in Myanmar, as well as the local program officers at state and regional levels, and also with the partners working in Myanmar. And to highlight WHO's support on this initiative, the support is clear that we support NMCP in developing the National Strategic Plan that is inclusive of private sector strategies and interventions. And we provided a technical support and also a financial support to have this project in place, and also to support the development of this guideline. And last but not the least, that Bill Gates Foundation was generous enough to support WHO and program to have this project that led to the development of the private sector guideline. Thank you, Sandy.
Thank you very much, Dr. Bhatri. We all recognize that private sector is also a multi-partner, multi-sectorial initiative. Implementing partners such as PSI have played an important role in supporting national governments in taking the first step towards engaging private providers. Kemi, can you share some of your highlights of PSI's experience in the Greater Mekong sub-region through PSI's GEMS program? And specifically, what are some of the areas of opportunity with respect to private provider engagement? And what are the challenges that you see?
Thank you, Sandy, and thank you for the opportunity to be part of this panel. As you know, PSI implemented a private sector engagement program between 2016 and 2019 in Cambodia, Laos, Vietnam, and Myanmar. The objective of the program was to increase coverage of quality malaria services within the private sector by helping them provide quality testing, treatment, and reporting according to national policies. What the GEMS project demonstrated for me is that it is possible to engage a wide range of private providers, both formal and non-formal, and help them to provide quality malaria case management. Now, throughout the life of GEMS project, over 3.5 million tests were administered by the private sector providers. Over 96,000 cases were detected, and those were reported into national surveillance health systems. At the highest point of the project, we had over 25,000 providers enrolled in the project, and they were accounting for about up to 40% of national testing and caseload in the countries we worked in. Now, we achieved this incredible result by working in strong partnership with national programs and partners like WHO as well, to map the providers, to provide comprehensive training, to ensure a solid supply chain of commodities, to monitor quality of care being provided, to also make sure that the reporting systems were adapted and aligned for integration into the public's surveillance system. In my experience through this program, what I've seen is that the private sector engagement works best where you have strong partnership with the national programs and other stakeholders, and where there's a clear vision of how the providers, the private sector providers, engage in the malaria elimination agenda. That's why I'm quite excited about the next phase of the GEMS project, where our mandate is to work over the next 3 years with the NMPs in these 4 countries to transition oversight of the private sector to their management. Thank you.
Thank you, Kemi. I would now like to turn to Dr. Mudenda for a perspective from the National Malaria Elimination Center in Zambia. Dr. Mudenda, can you share a bit about your experience with private sector engagement? And do you have a private sector engagement plan? What has been the highlights and what are some of the challenges in your opinion? Do we have Dr. Mudenda online? Okay, can we, maybe I'll skip to the next person until she returns. Okay, let me now turn to Mr. Anna. Mr. Anna, India has launched a very ambitious private provider engagement plan through its National Tuberculosis Control Program. I understand that one of the foundational building blocks for this program was the development of an electronic TB case notification system that could be used by private providers. Can you tell us about the private provider engagement strategy for TB, and also specifically share your experience with integrating the public and private case reporting system?
Thanks, Dr. Sandy. So for India, I think there has been a massive shift in how private sector engagement has played out over the last few years. The country's strategy has evolved from initially it was, the messaging to private providers was you need to refer the cases to the public program. Over the last few years, we've seen that evolve to let the private providers manage the cases themselves, and the program will provide access to drugs, diagnostics, and all the necessary support so that patients get effectively managed in the private sector. So with this change in the strategy, messaging, and mindset of the program, I think there have been few key interventions which the government and the program has taken. One, as you rightly mentioned, has been the development of online patient management and tracking surveillance system called Nikshay. Besides that, the government's also identified that to scale up private sector engagement, there's need to engage with agencies, NGO partners, and others to scale up the program. So there has been a few new models which have been developed in India, wherein intermediary agencies actually act as facilitators for private sector engagement. And the third key initiative taken by the government has been direct cash transfers or conditional cash transfers to providers and patients to engage with the program and ensure that services are being provided. If I talk about, the electronic case management system or the Nikshay system, it's been now last 3-4 years back, the system was developed by the government of India. The Nikshay system has both a mobile application as well as a web application. So it can actually be used directly by private providers, to notify cases. There are multiple ways in which providers can notify. As I said, they can use the mobile app themselves. They can call up a call center and notify, or they can send the information to the district program officers to notify cases. So providing a plethora of options to providers to notify kind of actually helped in improving access and ensuring that providers would notify cases. Additionally, the Nikshay system also simplified reporting. It provided easy access to information. It helped patients being tracked, longitudinally from point of diagnosis, treatment till completion. So, in terms of data management, surveillance, I think this system has obviously kind of improved access to information at all the levels, from district, sub-district level to a national level, and provides real-time information on what's going on. However, I think in terms of lessons learned and in terms of what's working well with the Nikshay system and what could potentially be done better, I think one of the challenges has been that right now the system is kind of an add-on to the paper-based management system which also exists. So for a lot of program staff, they look at this Nikshay system as additional work because the paper systems exist, and on top of it there is the electronic system. So if you really want to drive adoption, and I think there needs to be a plan to kind of slowly move out or stop paper-based systems and migrate completely to electronic systems. From a private sector standpoint, I think while this is a comprehensive surveillance system, expecting them to fill up all the data points, make sure that tracking takes place, it is sometimes challenging. Providers are happy to share basic information, but refill information, adherence data, all those become challenging for providers to kind of maintain and track. So providers need support, and that's where intermediary agencies come into picture. What they do as part of the program is they engage with providers, they sensitize them about TB diagnostics. They provide access to private sector patients to quality assured diagnostic tests and drugs. So at the end of the day, the providers only need to they can manage the case, and all the services in terms of drugs, diagnostics, follow-up services are provided by the program through these intermediary agencies. And finally, I think there is a need to invest in training of program staff as well as providers on these new systems, because any electronic system keeps on evolving over a period of time, and there's need for kind of continuous upgradation and training of program staff to make sure that the systems can be used effectively on an ongoing basis.
Thank you very much. Can I just perhaps give you another follow-up question? You mentioned the move out of paper-based to electronic reporting system. How long did it take, do you think? Because I think a lot of countries are challenged by that aspect.
It's still not completely transitioned. So as I said, it's been 3-4 years Nikshay system has been used, but currently also there is both the systems kind of exist in parallel, the paper-based as well as the electronic systems. Although I think compliance and usage of the Nikshay system has improved significantly, as backups, the paper systems are still maintained. So it is challenging. It's never easy to kind of completely transition off to electronic system, but I think India's pretty much on its way and in the journey towards that towards that end objective.
Thank you very much. I believe our colleague from Zambia is in the room now. So can I turn back to Dr. Mudenda for her perspective from the National Malaria Elimination Center in Zambia. Can you share a bit about your experience with private sector engagement? And do you have private sector engagement plan what do you think have been the highlights and what are some of the challenges in your opinion? Dr. Mundenda.
Good afternoon, everyone. And I want to begin by saying thank you very much for inviting me to be part of the panel discussion. I'm honored. Our experience here in my country is that we do not have a private sector involvement policy, but we do work with the private sector. And we are still in the process of coming up with an actual policy. An example that I can give in terms of case management. In the past, when we would form the new guidelines and we're doing trainings, we would only do it with the public health sector, but now we do it even with the private facilities. And I have to emphasize that the situation in my country is that I could say almost 90% of the facilities are public, because we only have private facilities in the more urban parts of the country, while in the rural ones, we don't have those because people just don't have the money to start going to pay to the private ones. So the few private providers in terms of case management are the ones around the capital and in the bigger provinces. So they make up just about 10 to 15% of the overall provision of malaria case management. But we have found a way of integrating with them in that when we update our guidelines, we make sure that we distribute even to them so that as they manage the cases, they follow that which we have put in our guidelines. And now we have managed to include them when we're doing certain on-site technical supervision and maybe proficiency training in microscopy. We've managed to include them. Of course, the challenge that we meet when we're doing that is that it's difficult for private providers to give you their lab personnel maybe for the whole week, because the training is for the whole week, because they are more commercial based than the public sector is. But we do manage to provide that supervision and assistance to make sure that the level of provision of service is at the same level that we have it in the private sector. We have also collaborated well with the private sector when it comes to vector control. And notably, when the country first began the indoor residue spraying campaign, the IRS, it was in the year 2000, and it was actually the mining companies that began it because they had noticed a lot of mosquitoes in their area, a lot of malaria, and it was impacting their productivity. So they began to spray their communities. And then bit by bit, even government joined in, and now it is a nationwide kind of activity. And even to date, we do collaborate in vector control activities with the mining companies and the bigger companies such as the sugar companies, many of those that have got a lot of workers and they feel the impact when their workers have got malaria. So that collaboration, sometimes it's in the form of the mining company doing in the malaria spraying, the IRS, not only in their compound, but in the district within which they operate. And then there are times when it is a situation where they may not be able to find all the chemicals, but the government can give them the chemicals and then they provide the manpower with their own manpower. Other times the collaboration is in the form of when we have a training, we get even those spray operators from the mining area and incorporate them. So we do work hand in hand. Is it without problems? No, it does have problems, like I mentioned, especially on the case management part, where it's difficult to get people who are in an income generating kind of a mode to come to away from their operation for a while. In terms of data, we're still in the process of checking how to get more of the private sector providers to get their data into our health management information system. As at now, we have the data from those that are private but non-profit, mainly like the mission hospitals. These tend to from the government and they do get the drugs from the government. But for those that are acting totally independent of the government, we are still in the process of finding out how to integrate their data into our data. So for now, perhaps that would be where I can end. Thank you.
Thank you, Dr. Mundenda. You mentioned, let me just ask you a follow-up question. because you mentioned about mining companies and sugar companies. And it is great to work with them when malaria is endemic and it's high and it's affecting their workers. What happens when we are moving towards elimination and these companies are not seeing cases anymore in their own workers or workforce? How do we continue to convince these companies that elimination is just as important?
What we have done is we have come up with something we're calling the End Malaria Council. And in that End Malaria Council, we have incorporated the big mining companies, we've incorporated the sugar companies, so that we have shared the vision to say this is where we're going. And when the cases do get low where you are, we still need to do the surveillance to make sure that we know which cases are endemic and we are still doing the reporting, and that we avoid coming back like resurgence of the malaria. So we have co-opted them in at their highest level into a body that has been charged to help with eliminating malaria in the country. So we have that buy-in. I could even mention that some of the companies are even helping to sponsor adverts on our behalf, because we have put them in one united body where they know that the aim is to eliminate malaria. So there's a feeling of wanting to be seen to be part of the malaria fight. So that is how we have gone around that.
Thank you very much. So we have hope then to continue working with the big CEOs and the big companies in the private sector for elimination purposes.
Yes, we do. And we have certainly told them to say that when malaria, if they eliminate malaria where they are, but it has not been eliminated around them, it will certainly come back. So it is to their advantage to help keep it out, not only where they are, but everywhere else, because we know that malaria does come back if the neighbors around you still have it.
Thank you very much, Dr. Melinda. I'm now going to turn to Kemi and talk about private providers. So Kemi, there's a widespread perception about private providers being primarily profit-seeking and driven only by financial incentives. Does this resonate with what you've seen from the GEMS program? And what are some of the approaches you use to motivate private providers? Whether it's around improving quality of care or ensuring regular, timely reporting?
Thanks, Sandy. When I'm asked that question, I'm often tempted to reply tongue-in-cheek that we're all motivated on some level by financial incentives. But on a serious note, to unpack that perspective or that perception a little bit, in PSI, we conducted research in 2018 and 2019, looking at the providers in the 4 countries where we work and exploring what factors motivated these providers. So in the quantitative aspect of this research, over 900 providers were surveyed. And these group of people who are looked on as solely financially motivated were motivated to do a good job because of 2 groups of factors. So the internal factors and the external factors. So for example, the feeling that my reputation depends on doing a good job is an external factor. And interestingly, we found that external factors such as those were linked to financial motivations as well. So if I'm more driven by external factors or motivated by external factors, and the chances are I'm also more motivated by financial factors. An example of an internal factor is a slightly more seemingly altruistic one, where I'm motivated because I want to take part in elimination of malaria in my community or in my country. We also found that these factors had regional variations within a country and across countries as well. And they were interlinked with each other. So it's not as easy as saying they're only motivated by finances or not motivated by finances. What we also did find in Myanmar and Vietnam, the Myanmar and Vietnam arms of the study, is that internal and external motivation scores were associated with a willingness to remain in the program, so to keep doing malaria elimination activities, even after partners like PSI exit and stop providing, support. So the findings were not as simple as finance or no finance. They're context specific within and across countries. Now, the qualitative aspect of the research also showed us some interesting things. So similar to what the presenter from Indonesia talked about, there's the desire to access free or highly subsidized commodities. There was also the desire to have continuing professional development, because from the perspective of the providers, especially in the GMS where national treatment guidelines change because of drug resistance, being engaged in programs like the ones delivered by PSI was the only way for them to keep their practice up to date and their training up to date. At least that's what they reported. And then they also valued the opportunity to interact with their peers in the community or within their catchment areas and across. So we have both quantitative and qualitative factors that push us to understand the more complex nature of provider motivation. And then the final point around the financial motivations comes from what we call the ACT Watch surveys. So they're outlet surveys that with the main objective of looking at the availability and price of RDTs and ACTs in outlets. And these were conducted across numerous countries over multiple years. And what we found was that in certain contexts, the providers who are engaged in programs like the ones we delivered in PSR are less likely to overcharge for services than the providers who are not engaged, right? So we've used this insight, one, to improve our programming. So having aspects of the programming that build on these complex motivating factors, but also to advocate to governments as well for more strategic engagement of the private sector, as opposed to outright bans of the private sector because they're financially motivated. Now, I'll stop here. I recognize I've thrown a lot of data and information out, and I invite participants to reach out to me if they want to explore in more detail the data or some of the work that we've done to respond to this. Thank you.
Thank you, Kemi. I think what you've said about provider motivation factors are really important. It's poorly understood, and I think there's a big gap between the understanding between the public sector and the private sector. So I hope you can continue to advocate for that. Let me turn to Dr. Bhatri now. Dr. Bhatri, an important question that comes up is around the effective governance of the private sector. From a WHO perspective, how should NMCPs be thinking about governance and policy change with respect to private providers?
Thank you. Once again, I think this is an important area. So, and also effective governance is all the more important. And as you all know that this is one of the important building block of the health system, as well as the community systems. I will draw your attention to the different documents that are published from the published in malaria by WHO. So we have our global technical strategies and the Greater Mekong Sub-Region Malaria Elimination Strategy and Malaria Elimination Framework, the Malaria Surveillance Manual. And we also published a Malaria Partnership Guideline in 2006 that talks about the governance as well as the policy change that the program needs when we engage these private sectors. And importantly, based on these global and regional documents, Myanmar has already developed the National Strategic Plan, which is already under implementation. And country has also developed the next strategy for the next 5 years. And the private sector strategies and interventions are clearly reflected in this document. And this is not standing alone, but these are built on the existing overall national health policies, as well as the National Health Plan for 2017 to 2021. And private sector has been clearly recognized as one of the stakeholders in implementing the health and including malaria in the country. So this means that there is a high level commitment from the government side to engage these private sectors as well as a service provider in the health. as well as malaria. And as I mentioned earlier, that malaria is going to be a notifiable disease in Myanmar. So all sectors, including private sectors, need to contribute to this notification. And overall, this notification law will be under this Myanmar Communicable Disease Law. And as you mentioned, that the effective private sector governance require more policy change. So I will be speaking based on what Kemi mentioned from PSI. That there will be a need for key policy change. I will just put it into 3 bullet points. First is the recognition of the private sectors, whether they are formal or informal. The country needs to recognize them for malaria engagement and also need to recognize their contribution. That would be important step forward. And second is on the regulation of the private sectors. There should be clear policies on the registration of the private sectors. I'm not talking about the registration of private sectors with the for health within the Ministry of Health, but there should be registration of these private sectors with the local malaria authorities. And this would be policy signing of the memorandum of understanding with the local malaria authorities. And accreditation will also be important. That will help private sectors to gain trust from the public, and on the regulation bodies strengthening like FDA. And clear policies on the sale of RDTs and anti-malarials in the open market in the private sectors. And importantly, the quality assurance aspect of this regulation, which is a good supervision, monitoring, and with the check and balances with the private sectors. And when we talk about the corporate sectors, and the corporate policies also should be in place, and malaria should be incorporated into their health programs. And third one is, once we have a legislation, once we have a regulation, but if we don't provide them some enabling environment from the private sectors, then our the legislation will not work. And this is also important in the context of what Kemi mentioned, the motivation to the private sectors that will keep them engaged despite of the projects, for the longer term engagement. And the policies are needed in terms of providing an environment to build the capacity to work properly for the malaria test, treat and track services, including other service. And this need to be equipped with free or subsidized RDT and drugs. And that is also important in terms of providing tools for reporting and notification. And Pranab already mentioned that the TB program has a long experience in India in engaging the TB service provided through the NICHE portal. Similar level of platform would be required in Myanmar if we need to move this forward. And Myanmar is already moving ahead in this dimension. And lastly, under this enabling environment, the financial incentive is important, but it is not the end. So there should be some non-monetary incentives in place, like providing opportunities for them for the professional development, and also organizing some continuing medical education sessions funded through the program. And lastly, on the engagement in the national and international malaria engagements, that could be a bigger meeting, which is not yet there. So thank you, Sandy.
Thank you, Dr. Japa. Let me now turn to Mr. Anna. I think private provider engagement is believed to be quite resource intensive and costly. How is a high burden country like India financing the private provider engagement for TB? And what do you think is the path for sustainability?
So thanks, Sandy. I think it's a bit of a fallacy that cost of private sector engagement is really high. And I can quote some numbers actually. I think some studies have been done which have shown that, let's say, the cost of engaging private sector for TB notification is in the range of around $90 to $100 per notified case. And in India, the cost, if you look at the national TB program, cost per notified case is around $150. So, I think the cost of private sector engagement is probably in the same ballpark or similar to cost of treating TB in the public sector in that sense. But yes, it definitely means that if you have to engage private providers, there is need to kind of invest additional resources for doing that. In India, as I mentioned, the approach which is being taken is hiring intermediary agencies and contracting out intermediary agencies to undertake this engagement on behalf of the program. So India has increased its budgetary allocation for TB program by almost 3x over the last 4 to 5 years. So it's increased from around $250 million to around $750 million in the last financial year. And that has been possible because of, I think, sustained political commitment to end TB, eliminate TB by 2025. And most of this increase in budgetary support is directed towards private sector engagement. So how are these resources being used? As I said, I think the government's now moving towards contracting of agencies to undertake private sector engagement. Historically, or till very recently, a lot of these projects were funded through donors like the Global Fund. Over the last 1 year, the government's launched a new partnership guidance document which espouses and talks about how do you engage with private sector providers, how do you get intermediary agencies on board to undertake private sector engagement. So that I think the policy framework is now in place along with the national strategic plan to kind of undertake these contracts with the private sector. Additionally, the nature of these contracts are more output-based contracts. So it's the agencies get paid only when they achieve certain targets which have been set for them. And otherwise there are penalties and other clauses. So this kind of addresses or kind of balances out the risk for the program as well. It doesn't lead to significantly high payouts if achievements are low in that sense. And to enable this contracting to kind of actually take place, the government's also I think there's a lot of emphasis on building capabilities at the provincial level for the state governments to actually contract these out. Service contracts are typically fairly complex and a lot of government agencies struggle to do that. So I think there's a lot of emphasis on building contracting capacity and capability so that such contracts can actually be rolled out and agencies can be brought on board. The World Bank has also, is providing support to the National TB program, and there's a 7-year grant, a 7-year loan which has been approved through which the World Bank is also providing and establishing technical support units to enable state governments and local governments to build this capacity and contract this out, this work to agencies in the future. That's all. Thank you.
Thank you very much. Maybe I can ask the last question back to Dr. Mundenda. I know you mentioned a bit about vector control and the role of private sector. Did you want anything more to add, for example, perhaps vector control activities or partnerships for vector control tools such as IRS or BetNets or other tools that you have in mind? Maybe not. I think we lost her again. Okay, I believe we have time for some Q&A directly from the chat room. So we will get some questions filtered out and will be directed towards our panelists. So just if you could wait for a few minutes, we'll be right back with you. Okay, there's a question for Dr. Wimpyotha from Myanmar. What percentage of RDT testing and malaria positive cases treated were from the private sector for 2019? Dr. Wimpyotha, can you answer that question?
Yes. From the private sector, there is a 5.4% of the positivity rate in 2019. The tested is approximately there is 10% of the tested rate, and the positive rate is 5.4%. Case detection is 5.4% contribute in the whole country data.
Okay, thank you. Please stay on the line because there are more questions for you. There are informal private providers widespread in villages, especially hard to reach areas. So the question is, are they already included in the forces fighting malaria activities?
This data include in URC data has included informal private sector, and also PSI data. There is a outlet private provider. It means the actually the not formal private sector. So we have a partial engagement of this informal private sector.
Okay, thank you. Here's a third question for you. From recent experience working with private GPs, it was challenging to get them to report malaria in a timely fashion using ODK application. Do you have any ideas of how they can be better motivated to engage in the malaria elimination effort?
Up to now, the private sector, general practitioner use the SMS and by the PSI and the mail reporting by the MMA, use the positive case notification by SMS and email.
MCNet သုံးတယ် MCNet with it or GB clinic တွေကို in Sakai region မှာ test we are state testing
OTK is we are state testing in Sakai region and Kachin State by the MC and Malaria Consortium here.
Okay, thank you, Dr. Wimputa. I think the next question is for Indonesia. The question is there a plan to impart mandatory case notifications in Indonesia? Pak Didak, are you still there?
Yes. Okay, thank you very much. Maybe I would like to ask my colleague to help me and to respond. Dr. Helen, please. Dr. Helen. Yeah. Sorry, Sandy, because I'm a new director in here, so maybe the technical about the program of malaria is Dr. Helen can follow until now. Yeah, Dr. Helen.
Maybe we can get your responses in writing, and we will feed it back to the people who are asking the questions.
Yeah.
Thank you.
Thank you very much.
Another question for Kimmy. Are those formal and informal private providers, do they reach forest goers? Is the question.
So where we've been able to collect data on the breakdown of the professions or activities of the clients, we found that between 60 and 80% of the people who the providers are testing are either forest goers or plantation workers.
Okay, there's a question for anybody who would like to respond. It's a question on vector surveillance and control. So the question says, we've had very little specifically about how the private sector has been or could be engaged in vector surveillance and control. Can the panel discuss the role of the private sector in the delivery of vector surveillance and control? Any takers? Well, let's have this be answered in a written response then. Thank you. Let me go to the next question. Again, a generic one. How can we convert the vast number of untreated mosquito nets in the private retail sector into ITNs? Any ideas? Okay, well, let's go to the next question then. This is for Anna. It says, I know that some country government programs and leaders worry about proliferation of third-party groups, like intermediaries for PPPs, as Dr. Anna just elaborated. Concerned that this increases the cost of delivery and may only be sustainable with external financing. What if it dries up or decreases? Will they remain viable?
Thanks, Sandy. So yes, I think that's definitely a potential concern where such interventions or such intermediary agencies are externally funded or donor funded. In India, as I was mentioning in my earlier question, the government is moving to actually contracting out these agencies directly through domestic funds. They're kind of moving away from externally funded agencies to agencies which are contracted out through a competitive selection process to provide these services to the private sector. That in a way makes it sustainable, because going forward, the government is going to use its own resources to get these agencies on board. In terms of whether these interventions are more costly versus, let's say, providers directly notifying or engaging with the program, there might be various models to actually, for private sector engagement to work. I think in India's experience, in country experience, we've seen that getting agencies on board helps in rapidly scaling up engagement. Because engaging private sector requires sustained efforts. It's not like a one-time effort. The program's also trying to provide access to drugs and diagnostics to the private sector. So someone has to do that. Typically within the program, there is not sufficient capacity to do all these external additional tasks. And that's where getting an agency on board kind of helps streamline and make sure there's some bit of quality and that's available and is provided to the private sector. And in terms of cost effectiveness, as I mentioned, I think as per some studies, the cost of engaging private sector through intermediary agencies is around $100, and whereas the cost of treating in the public sector is around $150. So I would say it's more or less in the same range. It's probably not significantly more expensive than treating public sector patients.
Sandy, this is Tiki Pang here.
Yes,
I'm not on the panel, but could I just contribute a comment?
Please.
Yeah, my comment is related to your earlier question about the role of the private sector in vector control. Okay, I just want to share my own experiences with vector control for dengue. Okay, and in the context of Singapore, for example, one of the main private sector sources of mosquito breeding is the construction industry. Okay, so in countries where there's a lot of construction going on, that part of the private sector is potentially an important source for mosquito breeding. Now, obviously, you could appeal to these companies and say, hey, you must do your part to make sure that, you contribute to vector control. But I think it's a combination of both the carrot and the stick. Like in Singapore, for example, if any of these private sector construction companies are actually caught not providing good control for mosquito breeding on their work sites, they can actually be ordered to stop work. Okay, the government has legislation to enable that to happen. Now, I'm not saying that you could sort of do the same in the context of malaria. It's just that there are many ways of getting the private sector involved. Obviously, it's better for this to be voluntary, but at the same time, if they are directly contributing, like in the case of these construction companies, then I think you also perhaps need a more sort of legislative kind of approach. So just a comment to contribute to the discussion. Thank you.
Thank you, Professor Tiki. I think this is a very good way to end the session. I would like to thank all the panelists who've been here and participated at this session. At this time, I'd like to invite Amita Chepi, Senior Director of APMEN, to share a summary of the discussions for this session and any specific recommendations that were highlighted as priority actions for the senior officials meeting that's coming up on Friday. Amita, over to you.
Thank you, Sandy. Wow, what a fantastic session. And I can really feel the energy in this virtual room. So welcome, everybody. I'm really missing being able to see everyone here today and remembering the last APMEN meeting in Bangkok last year when I got to meet most of you for the first time. So hoping that there will be a in-person meeting next year and that we'll be able to catch up. But thank you for making the time and joining us here today. Earlier this year, the APMEN Secretariat identified private sector engagement as a priority area of work. And this was really driven by the feedback we'd received from country partners who said that this is a significant challenge on their journey towards elimination and identified this as a place where they wanted more support. Now, we knew that a lot of the countries were already engaging with the private sector in some shape or form. So we commissioned a review to really look at what was out there in terms of existing tools to work with the private sector, alternative approaches and models that were being used by country partners to engage the private sector. And the result of that review is a report that we're launching today. This is a private sector engagement framework report that APMEN has developed, and we're sharing the link with you here in the chat box as well. The objective of this report is to really provide a framework for national malaria program managers that are starting to think about private sector engagement. And what it aims to do is really distill a lot of the experiences of partners in this space, whether it's country partners, implementing partners, guidance from the WHO, and all of that is really in the form of this easy to use framework that countries can use. I'm going to try and summarize some of the key points from today's discussion. It's a really rich, lively conversation, and I think it's given us a lot of food for thought on how to take this forward. As you all know, one of the main objectives of the APMEN meeting is to really identify priority actions that can then be taken up for further conversation at the APMEN senior officials meeting. So what we're going to do is condense a lot of the conversation here and try to identify a couple of key recommendations that we think would benefit from the attention of senior leaders at the SOM. The first one is, I think, very clearly stood out through the presentations and the panel discussion today, was the need to develop a private sector engagement plan. Now, like I said earlier, a lot of our countries are already working on this in some shape and form, but there is a real need to bring all of this together under one umbrella in the form of a strategy or a guideline that is really informed by the national strategic plan of your country, that can be used to advocate for resources for further private sector engagement, and really be a plan against which you track progress around how you work with the private sector. Now, obviously, this plan will look very different for different countries. because it needs to be tailored to a specific country context. It depends on your epidemiological situation. It depends on the health system that you have in your country. It depends on the social context. And of course, it depends on the resources that are available. So each country needs to develop its own customized country plan. I think we found this resonated in the presentation from Indonesia as well, where Dr. Didik really presented how they're thinking of private sector engagement in Indonesia. And the one point that really stood out was the fact that given their decentralized health system, they're thinking about private partnership with the private sector really at a district and provincial level. So yes, you have a national plan, but what's more important is really thinking through how does that translate into a subnational strategy or a subnational plan? And I think that's going to be really critical for several of our country partners. Coming to the second point, this is really around, and again came up in almost every conversation today, was the need for an integrated surveillance system that gives you a comprehensive view of the public and the private sector. Now, we know that there's several contexts where the private sector accounts for a large proportion of care seeking by patients. So in such a context, if you're looking only at the national surveillance data, you don't really have a true picture of the malaria burden in your country. And this is going to affect the way you think of allocating your resources more efficiently, as well as making sure that as well as unfortunately not being able to prioritize action for effective response. So really need a comprehensive public plus private view of the data. And I think the Myanmar example by Dr. Win Phyo Than really showed us that there are easy ways in which you can integrate the two together. And of course, this will again look very different from country to country, but you can use a combination of electronic and paper-based reporting systems. We saw that even from Mr. Arnab Pal's presentation and the TB experience in India. You can look at a combination of using community volunteers as well as public health workers. You can look at different ways in which you aggregate the data, whether it's at the district level or at the national level or at the subnational level. So lots of permutations and combinations that are on offer here. And I think countries need to think through what's the best way that they want to really start integrating some of this data. Coming to the last point, and which is probably one of the most critical ones, and which we hear from partners all the time as being one of the most important stumbling blocks around private sector engagement, is the issue of quality of care. And as we heard from Kemi and her experiences, with the PSI GEMS program in the GMS, again, there are some ways in which you can work and engage with the private sector to improve quality of care. This can be done through adequate training, providing commodity support to private providers, mentoring, and I think most importantly, making sure that they see themselves as being part of a partnership with the national program. This was reflected in Dr. Badri's remarks as well, the fact that you need to recognize, I think we cannot anymore continue to turn a blind eye to the private sector and the role that it plays in the national health system. Need to recognize the private sector and then find ways to engage with them most appropriately. Even as I say that, I know that with the increasing prevalence of VIVACs in the GMS, the issue of quality of care becomes significantly more complicated. This is because of the fact that you need screening for G6PD deficiency. The treatment protocols are much longer. So quality of care becomes a very thorny issue in that context. But our VIVACs working group within APMEN has been having several discussions on this matter. And this is again an area where we would continue to encourage engagement from all our partners. So thank you for this incredibly lively session. I think there's like I said, a lot of food for thought. We would encourage you to share your comments and feedback in the chat box. The idea is to distill a lot of this and share it in the form of recommendations to the senior officials. Thank you.
So I think it's time for me to take over. First of all, thank you very much, Amita, for the closing remarks and for the excellent summary. And remember what she said, make use of the chat box, because we're going to save all your comments. So if you have anything else to let us know, even maybe your comment find somehow the way into the SOM, please do so. Secondly, a big thank you to Sandy Wynn for moderating the session. And of course, to all her speakers in the session, thank you very much for joining. This is not the end of this call. It's the end of the first session. we are going to have now a break. Unfortunately, only for 5 minutes. So normally the APMEN annual meeting goes over 2 days. Today we have only 4 hours. So maybe a generous 5-minute break is not that great, but I hope you can get up, stretch, get a coffee, and be back in 5 minutes. And then I will hand over to another colleague, and we will discuss the critical role of community-based approaches to eliminate malaria and address other primary health issues and strengthen health systems. And so don't go away, stay online, mute yourself, switch off your camera, but come back in 5 minutes from now. And I think we're gonna play 2 videos for also indicating the time, and see you in 5 minutes from now. Thanks to all of you for tuning in for the first session of the Malaria Week. Yes, and I hope you have a coffee or tea. There's one colleague saying there is no tea or coffee. Then hopefully tomorrow you're better prepared. Thank you very much, Sandy Wynn again. And if you have to leave now, have a good day, but we sincerely hope that you can join us also for the second session and leave some comments or some love.
Thank you.
So thank you very much for sharing these two wonderful videos. I think we're going to try to share the links later in the chat box. Probably you will be also able to find these video links at the website of apelma.org. So I think given the time, we're going to start right away, and it's time for our second session of the APMEN Annual Meeting 2020. And as you have heard before, it's a session on the critical role of community-based approaches for malaria elimination. And I welcome all our participants who have been online already for nearly 2 hours. And of course, also I welcome everybody who just joins for this second session at our APMEN Annual Meeting 2020. So for the newcomers, just a reminder, please make use of our chat box and share your thoughts and comments there. And we're gonna videotape the session. And please keep your mics on mute and your videos off if you're not a speaker. So without further ado, I want to introduce you to the moderator and chair for the next session. Her name is Jocelyn Neukomm, and she's a consultant working with APMEN and APELMA, and she brings 25 years of experience in designing, implementing, and evaluating community health programs to the table, and of course, very much with a focus on malaria, but also other health priorities. And her technical expertise includes social and behavioral change, communication, social marketing, social franchising, and public-private partnerships. And Jocelyn, as far as I know, she worked in 11 countries in the Asia Pacific, and she's currently based in Phnom Penh in Cambodia. So over to you, Jocelyn. The session is all yours.
Thank you, Jost, and good afternoon, all of you. It's wonderful to be with you today for this very exciting and packed session from rainy Phnom Penh. We are very fortunate today to be able to organize this event with co-sponsorship in partnership with Comic Relief, GSK, as well as the Regional Platform for Civil Society Organizations, the platform in the GMS. So we are very fortunate to have this sponsorship, and as well as participation from a number of expert speakers representing our national malaria control programs, as well as civil society partners who are working in this space. And I am so looking forward to learning from all of our speakers, as well as our participants, about how to put communities at the center of elimination. We have a number of pieces of evidence and case studies to share with all of you to learn more about how Dr. Zung and Sartek explained at the beginning of today's meeting. We can all work together to implement multi-sectoral approaches, bottom-up, community-centered, and of course involving strong contributions from both the civil society and private sector channels, as well as our national health systems. I would like to briefly explain the plan for this session. We have 2 sections, and we will pause for discussion for some Q&A after each of the 2 sections. We would like you to please actively participate, use the chat function throughout the session. We really want to hear from you, your questions, your ideas. And as Anita has explained, we will be channeling today's discussion, both the key points from our speakers as well as your input, into a set of key messages that will be shared with senior officials and other participants in the remainder of the Malaria Week meetings. So with no further ado, I would like to invite Ben from Comic Relief GSK to officially open and give some initial remarks for us. Ben, over to you.
Thank you. Hi, everybody. Greetings from a fairly cold morning here in London. I just wanted to kick off, obviously, by kind of thanking you all for providing us with this speaking slot. It's my first Malaria Week this year, so it's a real pleasure to be here. And I'd just like to thank APELMA, APMEN, the GMS Regional Malaria CSO platform, and of course to Jocelyn for her kind of expert guidance in support of moderating and helping to organise this event. I will be brief, as I know that we've got a huge amount to get through in this couple of hours, but I just wanted to provide you, before we got into the panel of expert speakers, just a little bit of background about Comic Relief and our partnership with GSK, the Fighting Malaria Improving Health Partnership. So Comic Relief, we're a UK-based organisation. Some of you may have worked with us in the past, but I suspect in this part of the world, many of you haven't. So I thought it would be useful to just give you a tiny bit of information. We describe ourselves as an agency for social change. We're a UK registered charity. We fundraise from the UK public, working with celebrities and media talent and others. And then we make grants here in the UK and around the world. We have a really long-standing commitment to tackling malaria, and it's been a big focus of our work since we were launched back in the 1970s, during our flagship fundraising campaign every year in partnership with the BBC called Red Nose Day. We've consistently highlighted the impact that malaria has on poorer communities, in particular children and women. So in 2015, we joined forces with GSK to launch the Fighting Malaria Improving Health Partnership, through which we provide £22 million in grant funding over 5 years across 7 countries, 3 of which are in the greater Mekong sub-region, hence why I'm here with you all today. So our partnership has approached the malaria challenge as a key entry point from which wider health issues can also be improved. So this is a really kind of central part of the theory of change of our partnership. We believe that investing in the fight against malaria is a springboard for reinforcing the wider health system. And to deliver this in practice, all of our grants have focused on one, or in many cases, several of the following areas. So number 1 is increasing the supply of good quality healthcare. Number 2, increasing demand for and access to primary healthcare. Number 3, and I think really quite important for today's discussion and our work in the GMS, is strengthening surveillance systems and data management, both at the community, the district, and at the national level as well. And then fourthly, improved awareness of malaria challenges among decision makers. So that's why it's fantastic today to have so many representatives of governments from across the region here, kind of hearing case studies and stories of best practice and ideas and practical solutions for them to take forward in their work. So our initial scoping across the region led us to investments in Laos, Cambodia and Myanmar, and it's really wonderful, as I say, to be joined by some of those NGO partners and governments today. At the time, and still is, the region was in elimination phase. It was therefore critical for us to focus on improved case detection and community level diagnosis. The work we funded focused heavily on surveillance systems, data collection and community engagement, including comprehensive behavior change communication. So I won't delve too deep into the program, as we'll be hearing from several of the partners we worked with in the region who can no doubt speak to it far more eloquently and in more detail than I possibly could. But what I would like to finish on and stress is the critical role of community engagement in all of our investments there, as well as ensuring that our funded work was aligned with national priorities set by national malaria control programs and other instruments of government as well. So it's in this spirit that we wanted to collaborate with you all today to create space for an open discussion on best practice and to look forward at what can be done together to advance health outcomes and tackle malaria across the region. Thanks again for having us on. I look forward to hearing from this excellent list of panelists, and big thanks to our co-hosts again, and to Jocelyn for convening. Over.
Thank you so much, Ben. We're grateful for the support from Comic Relief and GSK, which has made this event possible. And now we would like to introduce our first section, which will review a number of pieces of evidence and case studies from two different country contexts. We have a lot to learn from our next three speakers, and it is my pleasure to introduce our first speaker, Dr. Tin, who is a technical specialist with Malaria Consortium. Dr. Tin has spent years at community level supporting community engagement, and we are very fortunate to have him with us. I would like to invite Dr. Tin to share his slides and kick off the session. Thank you.
Thanks, Joss. Thanks, Ben. Thanks, everybody, for having Malaria Consortium at this session. Thanks for the kind introductions. If we could pull up the slide, please. Today, we'll be sharing the work that the Malaria Consortium has done in Myanmar, primarily about the community-based approaches and delivering integrated health services for under 5 children, how that contributed towards the malaria elimination in Myanmar. So most of the information we have shared in these sessions will be based on our mid and end-line program evaluations of our own program, and including pulling up relevant evidence to support our messages here. Next slide, please. So in the context of Myanmar, where we are seeing a very varying epidemiology of malaria in the country, and primarily the evidence that we are seeing in Asia Pacific, especially in Greater Mekong sub-region, of dramatic reduction of malaria over the past few decades has been attributable by the work of the largely costed network of the community-based malaria volunteers. But at the beginning, these volunteers are trained as malaria-only volunteers, and there's a reason for it because we need to rapidly expand the quality malaria case management services, and training people on malaria case management is rather feasible to do at the villagers level. So these interventions could help us reduce malaria quite significantly. Now is the time to relook at how do we keep this success maintained and continue build up progress upon it. And one of the evidence that we are starting to see is, when malaria volunteers are coupled with additional healthcare services, that really helps these testing uptake to be really high at the community, and then led to overall continued reduction of malaria over years, as you're seeing in this study. And in our work, most of the main questions that come up before our implementation of a project is, will your volunteers able to do complex diagnosis, triage of differentiating danger signs, facilitate referrals, using commodities to treat simple cases outside of malaria? And in fact, we have found that they're quite capable of doing that. One evidence we're seeing here is malaria volunteers are able to diagnose common cases of cold, pneumonia in 5 children, are able to provide rational treatment within the alignment of the national guidelines. Next slide, please. So in another important aspect we need to look at the malaria elimination the countries progressing to malaria elimination is because of the low reduction of the malaria cases in the community, meaning community volunteers are seeing much less cases than they did in the past in the control phase. And that poses a particular challenge for community malaria volunteers to really maintain the testing and overall contribute to the highly reliable surveillance system to demonstrate that there is no transmission ongoing. So in our national strategic plan, in Myanmar National Strategic Plan, in our receptive area, we target that at least 10% of the vulnerable people who are suspected of malaria has to be tested by the microscopy or RDT. So to be able to do that, we need to attract people to keep testing whenever they're suspected of malaria, and this is particularly challenging, especially because of the risk perception change, and the acceptance from both provider side as well as community sides also started to change. Because more and more you test people, you keep seeing negative patients, and that really makes them think that whether their service is still relevant. And then you have a whole range of other health problems that communities have seen as a priority. Unless you're able to tackle them comprehensively, not alone managing in full, but if you could at least manage and facilitate referral and help connect them with the public health systems, you're starting to see a difference. And at the same time, you'll be able to attract them to keep receiving malaria tests at your service. So this is one of the approaches, evidence that we have found that we need to attach and expand the services of the malaria volunteers. Next slide, please. So another important factor is, as I mentioned before, as malaria cases go down, especially in elimination setting, people are starting to see more negative cases. A patient comes up to you at malaria volunteers, and you tested negative, and then you say, oh, there's nothing I can do more for you. If you have any other problem like fever, you need to go to the health system, and we all know that that's not going to happen, especially for people living in the remote setting who don't have the fortune to access to the towns or things like that. So one of the things that we need to look at is that what motivates the malaria volunteers to keep in their service, because that is really important until we reach the elimination. We need to maintain the service outlets. We need to maintain the service availability in all the communities. And one of the things that we have found out is it's once their roles has been expanded to be able to touch on the other health issues, it's one of the key motivator for them to maintain his service. And we need to capitalize on that as we transition into elimination. Malaria only serve volunteers are not going to stay for a while unless we have transformed their roles to be able to tackle more community health problems, including malaria. Next slide, please. Another things that we have to look at progressing elimination is we need to relook at how do we engage communities. And when I say community engagement, we need to mean business. We can't just do community engagement for the sake of doing it. And largely, malaria programs has been very vertical, top-down approach, where the healthcare workers are solution. We have the solution, and we give the solution to the communities without fully realizing the community expertise in developing that solution that they need. So in one of the different approach that we use in this project is called community dialogue approach, which is an inclusive dialogue platform that invite all members of the communities, all women and children to come together and to share their experience of the recent malaria or any other health diseases that they are interested, and we can share good practices. And one of the things that specific to malaria is to these platform, one finding that I find very interesting is how these dialogues help people to, repair bad nets, because it's when there is a tear, the airlines will not be effective at all. So platform like this, which really engage them to how to adopt this behavior. And there's one thing that we have to address, which is we shouldn't be sufficient complacent ourselves just to giving information to the public, because we need to take a look at this knowledge and attitude disconnect, and how do we adopt the behavior adoption, encourage the behavior adoption. I think one of these approaches are really helpful for that. Next slide, please. So I would like to leave this session with a message of, in times of COVID, in times of uncertainties around, we need resilience now more than ever. And one of the things that really captured us is how this project helped connect all the communities to the public health systems. Once the malaria volunteers, as you've seen in this case, as you acquire more new skills and knowledges, you're able to expand her service, make her relevant in the community, make her work more impactful, making her more motivated to do more work on that. So that is a positive energy we need to build on and to yield more public health impact, so as to her supervisors and feeling more encouraged to educate volunteers more, to support them to do their work better, and then help to connect to the public health system, the township officers, where these malaria volunteers act as gatekeepers, making that health service more accessible, as well as less burden to be put at the health systems. So thank you very much for this opportunity, and I'm available for any questions or comments.
Thank you so much, Tin. What a wonderful overview. There's a lot to digest there. I think among other things, you have certainly highlighted for us one of several data points, which really emphasizes the fact that community-based health workers can make a difference in terms of malaria service provision and other public health services. So the power of integration is certainly coming through. And I also very much appreciate Malaria Consortium's work with respect to community dialogue approach, which nicely emphasizes what many of us on this call know well, which is that community engagement is so much more than simply collecting information from communities or delivering information, products, or services to communities. It's a much more proactive and iterative process. So thank you for sharing that. And we will certainly come back to you with a question or two. But before we do that, let me introduce our second speaker, Dr. Quartet, who is the Deputy Director with PSI Myanmar, is with us to share some of the evidence collected in Myanmar by PSI. I think all of us will learn a few things from Dr. Quartet, including potentially at least one new acronym. Dr. Quartet, over to you.
Yeah, thank you very much, APMEN, GSK, and also Comiroli for inviting me to share this, our experience on community-based approach. It was a true honor to be here. And thank you so much, Josh, for your excellent guidance, how to prepare presentations and, fantastic moderation. So without further ado, let me proceed to the presentation. Yes. So today I'm going to share a bit about PSI community engagement in the context of malaria elimination. So next slide, please. So as Dr. Ting has mentioned previously in this session, so that community-based malaria provides us a place, a crucial role in the malaria control and malaria elimination in Myanmar. So as many of you know about Myanmar, it's very diverse and complex country. So we have extremely hard to reach areas, and we have a lot of ethnic conflict sensitive areas, non-government control areas, amid low public health spending and also with high out-of-pocket expenditure. So in the community setup, there are a lot of players providing malaria services, namely GPs and retailers, pharmacies, EHO service providers, CSO providers, and also village volunteers and even traditional healers. So those community providers are contributing significant malaria testing and treatment services in the community. In the previous session, I noticed that our national program manager has mentioned that over 50% of people who fall ill in last 30 days see services from the private sector. And also 65% of malaria service delivery is from the private sector. It is a very important context situation that before we proceed. Next slide, please. So PSI has been working in Myanmar for over 25 years, and our malaria program has initiated since 2003 with the general practitioners. So that gradually we have included that community volunteers and also outside providers and private outlets into their various networks providing malaria services. So far, we have over 3,500 community-based providers providing malaria services. In 2019, those providers tested over 500,000 fever cases for malaria with RDDs, and also have identified over 4,300 malaria positive cases in 2019 alone. Next slide, please. So that for those various kinds of providers, so the PSI has provided high quality training based on the national guidelines, and also provision of malaria RTTs and anti-malaria drugs, and also other associated fever case management tools and things like that. And also we provide regular data collection and also a quality assurance mechanism, for both data quality assurance and clinical quality assurance. We also provide health behavior change communication materials to be used IEC distribution and through the education session. And moving this forward, we also acknowledge that with the new national health plan, there is more demand for the higher integration of health services, and particularly We are providing integrated health services to like a private GPs and also community malaria volunteers using ICMD approach. So and then one thing to notice that in very recently, there were a lot of discussion about like a community-based health worker policy. I believe that will come out soon. The new policy call for greater integration of the health services at the community level. To be in line with the national health policy and provision of basic essential package of health services. So that PSI has been working closely with the National Health Plan Implementation Monitoring Unit, NIMU, about how this community-based health worker can be integrated into like a national health system using strategic purchasing or social contracting mechanism. So those are things moving this forward for the role of the expanding role of community health workers even beyond the malaria. Next slide, please. So this is for the community engagement. So that there is a PSI unique methodology calling EIP. So EIP stands for empathy, insights, and prototyping. So this is a multidisciplinary approach that we adopted from commercial marketing technique and also well-tested human-centered design. So empathy, that would allow us to understand what behaviors our communities are practicing, and also the why question of those behavior, why they are doing, behaving this way. So that empathy allows us, to put our consumer, our target audience at the center of our decision making. So we use like a day in the life exercise. We use the client's journey, whether their current health seeking pattern. We use who are their trusted providers, and we use other empathy tools that we put ourselves in the shoes of our communities, that and the way they see, the way they listen, and the way they feel, and then we consider their inputs in our program design. So they're also using this like empathy, finding, so that we develop insights. So the insights would sharpen our observation from the program and routine data collection. Insight strengthen our understanding of the audience, and the insight strengthen our like a deeper understanding of the program activities. And also prototyping. Prototyping is the thing that we co-create together with the community. So because community, they know a lot of this local context, so that when we create like a prototype together with the community, those solutions are not only feasible, but also desirable by the communities. So those are the like a beauty that, the use of EIP tools, how community can be actively engaged in the community engagement activities. Next slide, please. So here I'd like to share a bit about like one of the projects we were supported by the Comet Relief and GSA in 2017 and 2019. So we operated this project at 16 townships in 3 regions at northwestern part of the region, bordering with the China and India. So we conducted 2 insight learnings in 2018 and 2019 to identify provider behaviors to provide malaria services and understanding of their beneficiary health seeking behaviors. So we have learned that that there's that insufficient knowledge on the to do RDD testing for the every fever cases, and also lack of interest and awareness on the health education session. And also a lot of our audience, they typically first self-medicate before they do like they seek the proper care. And also the communities, they do not know much about like malaria prevention methods, and often confused like dengue and malaria and other diseases. So based on those insights that we updated IEC and education messages to be aligned with the the knowledge gaps, and also we committed to do more community engagement, so that we have done 2 more community engagement activities late last year and this year. And also we conducted refresher training and updating providers on the malaria knowledge. So to conclude, community engagement is the integrated part of the malaria programming. So it is the growing evidence that there's the malaria elimination, especially for the like a virus elimination, So without the community engagement, community-based approach, it will be very difficult, and then we need to engage with community more and more than ever. Thank you so much.
Thank you very much, Dr. Kotet, for introducing us to a new acronym, EIP, and equally, if not more important, for sharing with us PSI's experience using both private as well as public community level providers to achieve scale with integrated malaria and other health services in Myanmar. I think there's lots for us to discuss there, and we will certainly come back to you with questions shortly. But first, I would like to turn to our third speaker for the first section, Dr. Leonard Boaz, who is the Deputy Director for the Vector-Borne Disease Control Program in the Solomon Islands. Dr. Boaz brings 20 years of experience, technical and managerial, and we are very fortunate to have him, together with our other speakers, contributing to today's event. Dr. Boaz, over to you.
Thank you, Jocelyn, and thank you, everyone. Good evening and good morning. First of all, I would like to thank APMEN for inviting the malaria program from the Solomon Islands to participate in this session. I think, from my opinion, when we talk about community engagement, I think that's the last frontier for Solomon Islands, because as we work through the communities, we are still facing challenges and a lot of difficulties in how to invite communities to participate in the malaria control and elimination. So I will be very brief on my presentation. So, can I have my first slide, please? The second slide, please. Yeah, in the Solomon Islands, there's a few approaches that we deployed, that are deployed by the program for communities to participate in malaria control and elimination. When we talk about the malaria program, I think we have a lot of support from the government at some stages. But as I speak, I think most of our operations are funded by Global Fund, and I thank Global Fund for keep on supporting us in our effort to control and eliminate malaria in Solomon Islands. The few community-based approaches that we deployed that I can pick out, first of all, in 2018, we actually met with the government of Solomon Islands, with the Prime Minister of Solomon Islands, to develop this malaria elimination roadmap, which included on how communities are going to participate in our effort to eliminate malaria. Now, as I speak, I think we need more discussion on this malaria elimination roadmap. And just recently, we developed our malaria national strategic plan for 2021 to 25. And I think we have included some part of the malaria roadmap in that national strategic plan. Secondly, I think we have so many, more than 100 officers that are being posted throughout the country in all provinces. And these officers are responsible for the control and control, and they are trying their best to eliminate malaria in Solomon Islands by 2030. Now, however, as these malaria officers are responsible for all the malaria operations within the country, but unfortunately, we would like them to be stationed at the zone level, at the community levels, yeah. But we are lacking the logistics and infrastructure for our officers to be deployed all over the communities, especially in our health zones. Because in the provinces, we have health boundaries, and we call them regional boundaries and zone boundaries, which we would like our officers to base and work closely with the communities in terms of malaria control, carrying out malaria activities, and so forth. So in our 2021 to 25 National Malaria Strategic Plan, we are requesting to build infrastructures for our officers to be around the provinces so that they can do their best out of what we are trying to do in Solomon Islands. The other activities that we rely on is village healthy settings. Now, all year round we have been seeing our data have shown that there are pockets of villages that could not be controlled at some. The number of cases are still too high in those communities, and these communities are selected throughout the provinces, not only in one province but around all the provinces. And these village health settings is led by the Health Promotion Division of the Ministry of Health, and they go down to the communities and they select malaria village health promoter. That's what they used to call it. And we have developed guidelines on their responsibilities, on what they should do, and that and we actually have developed a pamphlet. It's like a kind of manual that they are going to use to educate people in those healthy village settings. So it includes talk about malaria, not only malaria, but NCDs, sanitations, and other diseases. So we have developed a big manual for them to do the job, carry out the activity of village healthy settings in the communities. So while in the communities, they have to engage the communities, do profiling, and give the community to develop the action plan on how to support them. Yeah, so they have the communities have to come up with some kind of a budget or support, and then we provide the tools and resources for them to carry out the activities of the village healthy settings. So that's and we are still engaging our health promoters and malaria officers in this village healthy setting as we speak. So there's a lot of budget on that, but I will come to that on the monitoring and evaluation part of that village healthy setting maybe later in my next slide. The other approaches the malaria program undertook is integrated supervisor visits that includes nurses, pharmacists, and health promoters throughout the provinces. So these are done quarterly or twice a year. So the malaria officers and other health officers used to visit health facilities to assess the success and failures of what we expect in the health facilities. This includes checking of the malaria information system, the data, and availability of malaria tests and treatment at the health facilities. At the village level, we have I think almost all health facilities in Solomon Islands have a village health committee, and these village health committees are responsible to look after the clinic. So during satellite visits by nurses or supervisory visits by malaria officers and other health officers to the communities, these village health committees used to meet them and accommodate them in the village. And they will be responsible to organize the villages on what the health officers expect them to do the next day. Either they have to come together to meet and do discussions on what they are going to do. On how to reduce malaria and talk about other issues regarding to health. The other one is the inclusion of malaria disease as a subject in the school curriculum, I think, and school visits by malaria officers. Yeah. So this is what we also have included malaria subjects in the school curriculum throughout the country. And it's we provide manuals for all schools so that teachers can teach children on how to prevent, diagnose, and treat malaria. In terms of school visits, I think this is part of our operational plan where we officers of the malaria have to go to community high schools or secondary schools or tertiary schools to do awareness on malaria and other activities that are required. Next slide, please. So what do we learn about our experience on these community approaches is that on the first point, I think we need more discussion on this malaria roadmap that was developed in 2018 by the Ministry of Health and the government. As I said, I think we have done a lot, but we would like to expand to the peripheries of at the provincial levels for officers to be stationed at the right place where the, malaria is endemic. So we need proper logistics, adequate resources, and infrastructure on that. Health awareness is one of the activities that is carried out almost every year, and at least I think all communities, around 70 to 90% of the population have been visited every year, but we are still we still have to get an impact on how we can convince or the proper way to encourage the communities to participate in malaria reduction and elimination. I think because this activity is have been in our budget for quite a while, and we include the health promotion division and the malaria officers to carry out awareness in hotspot villages. So during that time, they used to give them feedbacks on their malaria data, the malaria situation of the village. Yeah, so they are advised to look after themselves, sleep inside the mosquito nets, and everything about malaria prevention have been talked about during those awareness period. The next experience we have is we have been doing this health village setting for a few years. It was a project by the Japanese embassy, JICA, and they are still supporting this village health setting model. And a few years ago, we have been doing that, but then to sustain the the ongoing success of the program of the village healthy setting is not easy for the communities. Yeah. So after a while, when the project lapsed, they don't do nothing. Well, we yeah.
Dr. Boaz, I'm very sorry. Please excuse me for interrupting. I just wanted to let you know that we're a bit over time.
Oh,
so if you could kindly help us focus on your remaining key points. I'm very sorry because clearly you have a lot more to share with all of us and we will have to find an opportunity to follow up. But we are over time now. So if you could kindly help us wrap up, please. Thank you.
Okay, thank you. Like drug shortages and compliance is still a problem after being advised by nurses and malaria officers. Some of the village healthy committees are not functioning as expected at times. Next slide, please. So in terms of leverage of the activities, I think so far the malaria program is still being prioritized as one of our public health disease in Solomon Islands. And so far we haven't got any positive COVID patient in our country. So we are still running normal with our programs. Next slide. Although we do participate in COVID response. So the added values, as we know, community participation has been stressed by other speakers, improve health and health services in terms of high coverage and community ownership of health facilities and improve of drug access and prompt diagnosis and treatment and malaria prevention in communities. I think that should be my last slide. And is that it? Thank you.
Thank you very much, Dr. Boaz. What a wealth of evidence and insight. And among other things, we particularly appreciate you sharing not only the achievements, but also some of the challenges, particularly in these times. So thank you for that. One piece of your presentation that I think is particularly relevant to the participants today and all of us in the region working towards elimination by 2030 is the importance of that bi-directional, two-way communication with communities. So again, reinforcing some of the earlier remarks about the importance of not just thinking about community engagement as collecting input from communities or delivering a product or service. I will come back to you with a question, if you will, in a minute. But first, let's loop back to our first speaker and ask Tin to please give us a little bit more detail. One of our participants, Louis de Gama, has asked for more details about how different partners in the region are mentoring and coaching community-based volunteers, and that links to the part of your presentation where you spoke to the importance of properly trained, supervised, and supported volunteers to help eliminate malaria and address other child illnesses. Tin, can you share a minute or two of additional insights with respect to this question?
Thanks, Jocelyn. Thanks for the questions, Louis. So in terms of training and supervising the malaria volunteers, it's a critical component, especially generating quality services out of these providers. It's very important. And one of the approaches that we tried in this project, which could be quite different from other NGO actors working on malaria elimination, would be the training and supervision that we use are embedded within the public health structure, which means our staff didn't really provide training themselves to the volunteer, but rather the basic health staff. It's the basic health staff, their midwife and health assistants are the one who's training them, and we as a facilitator provide a training of trainers to those people as well. So part of that element is to ensure there is a sustainability. So once the Malaria Consortium for instance, like stop working here, that basic health staff has enough resource package to go and train them. When it comes to supervision, and I think I want to emphasize on the supervision element quite importantly, and especially in malaria elimination. So supervision is the only opportunity that we have the supervisor and malaria volunteers to ensure that communities enjoy the best service possible. Especially in the cases when the volunteer is very natural. It's when you stop seeing malaria cases, you started to forget about the treatment algorithms or treatment guidelines, for instance, or how to perform RDTs even. So this needs to be refreshed regularly. So in our project, we use a standardized quality supervision checklist. And this is important because in Myanmar, there isn't any standardized methodology approach to supervising these malaria volunteers. So using this, and we developed this little checklist together with input from the basic health staff who are actual supervisors of the volunteers, because they know which issues are most pertinent to the service quality. And then it is a collective process we develop in that. And then that tools encourage problem-solving approach, because when you go and supervise people, it's usually collecting data, replenishing stock, and you go back and move on to the next village. You couldn't do really quality supervision at the service provider, especially at the village level. So that checklist and uses a problem-solving approach, and also open feedback session between the supervisor and the volunteers. And one of the shortfall that we found with supervision is many of the observations we made in one visit are not routinely follow up in the next, because we're going to make sure whether they're implemented or not, whether the volunteers still have issues and challenges to implement those recommendations. So we encourage that in making sure that the observations are well documented, and so they'll properly follow up to the next visit. And all these data from those are reviewed regularly in the quality supervision meeting, quarterly meetings we bring in together the basic health staff, the volunteers again, and then we review all the issues and challenges, because one issue could be another problem, another person could have a solution for that. So then we facilitate that knowledge transfer processes within these quarterly meetings. So that's the best use of facilitating knowledge transfer.
That's wonderful. Thank you so much, Chin. What a consultative solution to coaching and mentoring at the community level. Thank you for sharing that. I would like to turn back to Dr. Quartet now. We have a question from one of our participants who's very interested in your EIP technique and would like you to, if possible, share a few very specific solutions that emerged out of the EIP process in Myanmar. Over to you, Quartet.
I'm very happy to share. So last year, August and September, we did an EIP study in northern part of the Manali region. So Manali region in Myanmar, in the central part of the country, in generally there is not many malaria, but in that one particular region bordering to the Shan state, there are a lot of malaria cases, and then we wanted to know why. So that we did an EIP study. I was involved in the entire data collection and entire throughout the process. And we have identified that there were a particular area where there is a illegal lodging site between Manali division and Shan state. So that is the ethnic group control area. So that not many people can travel to that area. So that we asked a forest goer, what they are health-seeking pattern, if they are having some malaria. So the response they gave was before they go to the forest, they bought a package of a medicine with them, right? So then after that they go to the forest, they stay in the forest 3 weeks or 1 month. So if they think they have fever, they took the drugs first, and then if fever cannot subside for 3 days or 4 days, and then they have to find someone to come back to the village. That is about 4 or 5 hours a motorbike drive. So there is actually no one, no volunteer, no even private outlets in that this illegal lodging area. So that we have identified these insights. And also there is no internet network and Wi-Fi, no Wi-Fi a mobile network coverage in that area. So that communication is very difficult in that area as well. So then basing on these learnings, so that we identified that there could be a potential a PR worker who can be work as a malaria volunteer, but also we acknowledge that reporting will be very challenging for them. It's any other volunteer programs. so that we identify and train these like a forest grower as like a peer service provider, and then that anyone who suffer from like a fever or malaria like symptom can go and treat from the peer educated peer service provider. That is a one particular the example that I will give. Thank you.
Thank you, Dr. Kotet. Those additional details are very helpful in bringing the EIP process to life. And now we would like to turn back to Dr. Boaz and ask Dr. Boaz to provide some thoughts, to share some thoughts with us in terms of how he sees community engagement and community-based health workers, including the initiatives that he shared with us from the Solomon Islands, as contributing to broader health system strengthening efforts in the Solomon Islands. What Dr. Boaz, can you share with us a little bit more of your thinking in terms of your vision for community-based health services for elimination and other primary care needs contributing to the Solomon Islands efforts to strengthen national health systems?
Yeah, thank you. I think in terms of community volunteers, I think we are trying to embark on that, but now I'm just wondering on how they give incentives in some parts of Asia, but because it all depends on the government system that we are in, yeah? Because the government would not be able to hire volunteers. They have to be employed by the government. So as I look at it, it's one of the difficult tasks that we are going to face, because during elimination, we would like to get community volunteers to assist in our efforts to eliminate malaria. But then we are still working on that. And in terms of, I think there is a plan to integrate our health teams during supervisory visits to the communities and the health facilities, so that we can identify gaps that are experienced in the communities. So as we speak, I think the communities themselves have been, they know about what is malaria, how it is transmitted, but then to fully participate is, I would say, it's a challenge, because they have different priorities at the community level. So I think the ministry and the malaria program need to work hard with other stakeholders, civil societies such as World Vision and women's group or church groups, to assist the malaria program in its effort to eliminate malaria.
Thank you, Dr. Boaz. Words of wisdom and quite, I think, pragmatic insights about the opportunities, but also the challenges. I would like to thank our first three speakers, and please stay with us as there may be additional questions for you later in today's event. At this point, we are going to transition to the second half of our community engagement event, and we are now going to look forward. So we have just reviewed some of the evidence and country-specific experiences from the recent past with respect to using community engagement to support the goal of eliminating malaria in Asia Pacific. And we are now going to shift to a discussion about the more recent experience and forward-looking learning with respect to community engagement in times of a pandemic, and also with respect to significantly underserved communities, including communities at the border areas. And with no further ado, I would like to introduce the first speaker in the second section. We are very fortunate to have Dr. Afsana, the Deputy Director from Bangladesh's National Malaria Elimination Program. Dr. Afsana is an accomplished public health champion. We are very fortunate to have her with us for Malaria Week. Dr. Afsana, over to you.
Thank you so much, Jocelyn. Hope everyone is doing good, and good afternoon from Bangladesh. It's a delight to be in as a participant in this program. It's a big program, and it's really, I'm fortunate to meet all the technical people from the malaria who are actually the fighters to eliminate malaria from the world. So thank you so very much for giving me the opportunity to join with you all. So I have a presentation, so can we switch to the presentation part? So I think the time is really short, and I can start presenting from my side. Thank you so much. Hope everyone is able to see my slides. Next slide, please. This is at a glance what actually the present situation of malaria in our country. You know that we have not all of the country is affected by malaria, but there are 13 endemic districts they are affected. And within that 30 endemic districts, we have small upazilas. It's 72 upazilas are now. And the risk population is 19.5 million. And over the last 10 years, from 2010 to 2019, the cases has been reduced 69%. If you can see the figure, it's 55,873 to 17,225. And the death also decreased 76%. It was 37 to 9. There are all the cases are coming from the 13 districts. There are 3 main districts which are actually in our importance. They are Rangamati, Khagrachuri, and Bandarban. These are the hill districts. We call them Chattogram hill districts. So more than 90% cases are coming from there. And there is 8 districts which are in the brink of elimination. And you will be happy to hear that from the last 10 years, around 12.7 million free L-Line has been distributed to overall the 13 districts, 13 endemic districts. And we have to thank Global Fund for this, because they were really helping us on the distribution and the buying on the procurement of the L-Line. Next slide, please. So here are, I want to tell you that this is the community-based approach, what actually Bangladesh is now experiencing. You know, Bangladesh has been in the phase from control to elimination right now. So from the National Malaria Elimination Program, with the help of the BRAC-led non-government organization consortium, so we are working together as a partner. And free malaria services at the doorstep of all the households we were providing. Around 139 peripheral laboratory in the community is established right now. And the L-Line distribution, I just let you know just a few minutes back. Community awareness, how we do it, we make like they have a small group of people, they sit in the yard, just front yard, we call them uthan. So they were sitting there and they're discussing and they were giving the awareness that what you should do. So we called it Uthan Boitak, like lots of people gathering together and they just sharing their knowledges. And we also make some theater and folk songs for them, for the people. You can see in the pictures, you can see it, that we arranged these things among the community. And for the sustainability, what we did around, it's our government manifesto that the government is providing till the root level the services. We call them community clinics, CCs. So we had around 1700 community clinics in those areas. and more than 80% cases are treated in that community by those healthcare providers. Less than 3% is severe malaria. I hope you can hear me. I just maybe lost some of my comments, but hope you can hear me. So the next slide, please. Next slide, please. Yes. So this is what we are actually going with the COVID pandemic along with malaria. So this is really tough for Bangladesh. You know that when the case is not identifying as you are expected, that means you are actually in danger, grave danger. Because malaria, it can spread from one zone to another zone by transmission, by the mosquito transmission. So also the human transmission. So we are really in a grave danger in this COVID situation. You see the case has been reduction till July. I am showing you the slide. Till July, 54% case has been reduced, but it's not bringing any happiness for the program. It's actually giving me much pressure that the case has been reduced. It's not identifying. We are not identifying. And the tests also reduced. So these two are not giving us a good thing for us. If you look at the bar chart, you can see in April, it was like really low than the previous years, 2019. So it's really low. So from that, we try to catch up. We went through I myself, in this COVID situation, I went to those hill districts and tried to actually giving them some kind of boost, moral patient. They had to go with for the case identification so that they have gained some faith that the government is with them. They're not. We give them some IPC that how they can use mask and go to them, and they treated patient. So from April, you can see like June, July, it's also increased. But the thing is, the number has been decreased, and the number of death is increased till February, till July 2020. In 2019, it was 3, but in 2020 till date, we got 5 deaths. So we heard that I read somewhere, and one of my professors said that 40% death will be increased in this COVID situation, and I think Bangladesh is experiencing a little bit, and it's really time for us to work really hard for this. Next slide, please. Next slide, yeah. So what we did in this COVID situation, I just gave you a little bit of glimpse of that. We make dengue and malaria around with COVID. We had training for the health professionals. There is awareness, and protective materials has been distributed among the community workforce. Awareness counseling also given with to the community workforce. LLIN distribution in small clusters. Rather than the mass gathering, also we had it. The peripheral laboratories, we kept it functional in spite of this COVID situation. Community counseling during the household visit of the health workers is also, we tried to maintain this till now. What we did, because there was lockdown, and we had the Malaria Day, World Malaria Day on 25th April, we started miking of awareness of malaria, that what you should do. So because you are not going out, but for them, because they need to know, so we did the miking to all the areas, 13 districts. And we distributed BCC materials like leaflets, stickers to the community. And also they have focus investigation, case investigation. Wherever we are getting cases, it's all also continuing we are continuing it. Field visit from the central level. I told you that me, my team, we went to the field in this COVID situation, and not giving, actually, I'm not telling that I'm brave, but I'm trying to think about my people, that they need to, the health professionals, their moral boost up needs, because they are my main workforce who are working in the field. And we have regular online meeting with our surveillance medical officers, as well as the NGO program managers and whoever is working. We maintain these ongoing meetings every month. I mean, every week we have 2 or 3 meetings. So it's going on till now. Next slide, please. So this is a glimpse of pictures. If you can see that they're wearing their mask, they went to the households, they're keeping social distance and giving them awareness. And also you can see in the last picture, you can see a little bit of glimpse of me. I went there and I wanted to see whether they're using the long-lasting nets, and the long-lasting nets is actually working. So this is one of our main thing. And we have miking. You see that people are there and they are doing miking, and also the people there, the laboratory people, they are doing tests on the spot. So these we are maintaining in the community level. Next slide. So this is actually what are the challenges we face. I told you that the screening of suspected malaria cases, fever, it slowed down. And the sub-center, outreach center, these are closed for the lockdown. So it is also for us a little bit challenging to get the cases. Distribution of L-line, it was withheld for 1 month. And you can understand, if 1 month is locked down, how crucial it can be for the people who are living there. And the frequency of the household visits also came. Case facility level, cases at the facility level has been reduced because people are in lockdown, they couldn't come, and identification of the cases goes down. And also the physical monitoring and supervision going a little bit less. So because of the lockdown, we cannot go all the time as we are supposed to do our routine visit. I think this is all for me. So the next slide, maybe. Thank you. And if you have any questions, you're open. I'm trying to give you everything. This one is actually what, this slide is actually, previous slide, please. It actually shows that how we are going to eliminate. The colors you show, the green, yellow, and red, it's actually showing that from what timeline to what timeline we wanted to achieve Bangladesh's elimination of malaria. So I'm not going to go to details. But I think this map is kind of self-explanatory, and I'm not going to take more time. So thank you so very much.
Thank you so much, Dr. Afsana. I can see in the chat that we have a number of questions for you, so please stay with us if you can. It's really remarkable to see how Bangladesh has sustained malaria services at community level in COVID times, even with the refinements that you have explained. And with the drop in case finding, in testing and case finding, as would be expected. So I think your presentation has remarkably summarized some of the challenges and also some of the innovations that Bangladesh is leading and that so many other countries in the region can learn from. So thank you. We will certainly come back to you in a few minutes, but first we are now going to turn back to the GMS and invite Dr. Siv to join us. Dr. Siv is the malaria manager for the CNM, the National Center for Parasitology, Entomology, and Malaria Control in Cambodia. And Dr. Siv has a wealth of experience that he's going to share with respect to the CNM's experience sustaining and adapting community-based services in COVID times and in the border areas. Dr. Siv, over to you.
Yeah, thank you. Welcome from Cambodia. actually, during the COVID-19, everybody affected all the world and also Cambodia. But we have a role to eliminate malaria in Cambodia, especially PM malaria need to be eliminated by this year, 2020. Besides of COVID, national program has been the work very strong, and the achievement has been still going on. As a result, I can tell you that more than 70% of cases has been reduced this year compared to last year. And especially the PF malaria reduced 80% compared to 19. And we keep 0 deaths since 2018 until now. And in contrary of the COVID-19, our death rate still increasing around 50% compared to 2019. How can we sustain these activities on the ground properly? We have been during the COVID-19 pandemic in the country, we have been take some action to do reassessment of what is the COVID-19 effect to the malaria activity in the country. And through the assessment, our program has been developed operational plan that has been sure that we can continue our essential malaria services during the COVID-19 pandemic in the country. The regard of that, we have been classify our reassessment with the low risk, medium risk, and high risk in the purpose of how to mitigate all these risks during COVID-19 pandemic in order to make our malaria activity is going on. Besides on that, from the extra support from the donor and also the government, national program has the ability to distribute some PPE to the community network and also our health staff at the subnational level in order to make sure that they can still feel safe to still provide malaria services during the implementation. At the community level, we are make sure that the service still going on, and some guide have been produced as a flip chart in order to make sure that they still provide service to malaria. And this is very important. That's a key point that everybody had to make to know that in order to get good service from the community, you need to make community feel safe during provide services. We also continue attending the monthly meeting with the community network, but rather than gather in one place, we are individual schedule of the people come into health facility individually in order to make sure that they still can have malaria commodity supply during their implementation activity. And beside on that, we also have a challenge that there is a internal migration increasing, especially the foreign activity in Cambodia, because of most of people has been come back to the country from neighboring country, from Thailand and Vietnam, because of the close out the border during the COVID-19. So everybody has been try to looking for some work in the country. So internal migrant has been increasing, and also forest activity has been increasing. So through this challenge, how can we mitigate to this activity? We have been set up hotspot services at the entry and exit point to support the inflow of migrant workers at risk occupation, especially when they go to the forest, and also at the border we have been provide some protection to the quarantine place at the border. So this make sure that even they are in the quarantine at the border, they have protected from malaria. We has been ensure the community availability in all level. We have been still conduct a virtual meeting and with stakeholder, with implementer, to make sure that every week, every 2 weeks, in order to, sorry, every 2 weeks, not 1 week, every 2 weeks, in order to make sure that malaria commodity are available on the ground, but to make sure that no stock out of malaria commodity during the COVID implementation. Besides all that, we have been shift our BedNet campaign to the how-to-how strategy campaign rather than do a mass campaign. And you know that we have been hold on community mobilization activity due to the COVID-19. We cannot gather people in one place, but we still the guide the subnational level and community by using the social media like Facebook, and also using the loudspeaker player, and that with the pre-record malaria education at the community. And so this is the some activity that's still going on in the community at Cambodia. But additional to that, Ministry of Health and national program and also multi-sectoral has been still have whole conduct every meeting. They call the malaria task force meeting in order to make sure that all the problem has been solved on time and in the real manner. Thank you very much.
Thank you so much, Dr. Sev. It's a pleasure to have you with us today and to learn a little bit more about how Cambodia has sustained community level services for malaria in COVID times. And quite well. It's also very interesting to hear you explain the support that has been provided to sustain service delivery along the border areas with the 3 countries that Cambodia shares border with. We will certainly come back to you with additional follow-up questions after our 3rd and final speaker. Let me now introduce Dr. Tet from Health Poverty Action. Dr. Tet is based in Laos. He is the Deputy Director for HPA, and he will be sharing with us today some evidence and learnings from HPA's experience implementing elimination services in Laos during COVID-19 times. Dr. Tet, over to you.
Thank you very much, Jocelyn, and hello to everybody in the call and beyond. It's a good afternoon and maybe good morning to some of you, depending on where you are. Maybe I would just go directly to my presentation if you can put it up. So I'm Seth, and I am currently working for Health Poverty Action. Today, I would like to spend 8 to 10 minutes adding my opinions to this auspicious event, particularly around the community engagement and the challenges to sustain the community engagement in the time of COVID-19. So if we go to the next slide, I would really like to focus on 3 key points, which are three key points regarding the challenges, or if you may like, I would like to call them as recipe, because I am kind of a person who really loves to spend a lot of time in the kitchen, cooking, whenever I run out of idea while doing some work. So the 3 key points, which are pretty important in making the beautiful or delicious outcome, which is the community engagement, are data, partnerships, power, and politics. So by data, I mean not only the data availability, but also how we use the best out of data available to us. Of course, data availability is not an easy thing, depending on the context and the country you are in. And again, even if the data is available to you, you and your partners might not know or might not be able to analyze or convey the messages or the evidence, if you would like to call, to the key stakeholders. And the second bullet point is actually the partnerships. In that particular element, I would really like to take this opportunity to thank everybody in this call and beyond for all the efforts that you have contributed towards sustaining this strong partnerships, not necessarily in GMS region, but also globally, from the south to the north and from the south to the south. But I feel individually that these sort of partnerships are pretty crucial, and we have been quite lucky to have this sort of partnerships already set up. Although they are not yet perfect, I think if we go on with this pace and synergy, we can definitely tackle whatever challenge we have, not only COVID-19, but also whatever challenge. I won't say another pandemic. And the second, the third, but not the last one, is the power and politics. It's pretty immensely broad topic, but what I have observed so far is the role of the decision makers, the role of people who are in the position to make not only the political decisions, but also maybe someone who can decide the direction of the programs, the direction of the sectors, or maybe even the direction of the community sectors. So that is pretty important. And a lot of things really rely on the power and politics, and how well we are committed to that is something we can regard as a recipe or maybe a challenge in this particular case. So without further ado, I would like to present to you a small example from my observation and from my work experience in Laopedia with Health Poverty Action and other partners over the last 6 months in particular. So the slide in front of you is actually the total of the malaria tests across 5,000 provinces in Laopedia from all the sectors, that is public at the facility level and private, and also community level testing. So it's quite obvious in the graph that there is a steep decline in the month of April 2020, the orange line, in compared to the data point in March. And as you may see, the source of the data is actually from HMIS of the government of Laos, also known as DHIS2. It is one of the good examples that the DHIS2 in Laopedia is not only robust, well, maybe it's quite an overstated, but pretty advanced already. And that the best thing is that it makes accessible to the relevant stakeholders, and it also helps us analyze a lot of data as long as we can access the system. And if we look into the next slide, please. This is the fresh analysis that we did in September. So there is actually the, how should I say, the upward trend of the orange line again in May and June. And so this is pretty, how should I say, positive. But although this is quite a small line on the graph in front of you, it is actually contributed by a lot of excellent contributions from every partner. If I have to mention some names, the organizations, like UNOPS, WHO, with leadership from the national program and the collaboration from the civil society organizations in the country. So if we go to the next slide. This is actually focusing on the community level testing of the malaria volunteers, and actually in compared to the all sector total testing, it is not a significant decline in the test, but you can also observe a slight decline in the test. But the point I would like to mention is that we did not stop at this point. We continued to make a lot of conversation and discussions, and some of the key questions are like, hey, what is the village level testing? What's happening there? And if we go to the next slide, we will see that it's pretty granular analysis, and we sort of like made the action together. And we, of course, have limitations in the time, in terms of time, workforce, and everything. So we have to know where we want to prioritize, where we want to focus, and where we want to learn regarding these decline in the testing of malaria. So if we go to the next slide, please. We made few field visits to those particular areas, and we learned 3 key points. The first one is actually the volunteers did have experience stockouts of malaria commodities, which is not necessarily due to the poor management, but more on the lockdown measures, and also some parsimonious management of the commodities at the head center level, because they are not very sure how far the lockdowns would go on and how far the COVID-19 situations would go on at that particular time. And the second observation was the slight change in behavior of health-seeking patterns in the community. And the last but not the least is the level of comfort in the volunteers. They were not very comfortable to provide malaria testing when they did not know how to prevent themselves from contracting respiratory illnesses like COVID-19 while they provide malaria testing and treatment. And also they did not really feel comfortable because they feel like they were not well protected using the proper materials like fabric mask or surgical mask and hand sanitizers. So we did make some decisions, and we also reached out to our partners, and we also managed, if you go to the next slide, we have managed to provide surgical masks and hand sanitizers as a material support to all 2,000 malaria volunteers in 5,000 provinces of Laos, which should cover 3 to 4 months malaria testing in the community. And I think that's all about it. My presentation. Thank you very much to everyone. And yeah, it's been a pleasure.
Thank you so much. Thank you, Dr. Chat. You have certainly shared with us quite a lot in a very short time. So thank you for that. And in particular for sharing HPA's recipe for success, if you will, in terms of sustaining community-based services in COVID times. We very much appreciate you highlighting the importance of motivating and protecting frontline community-based health workers in these times. And I can only imagine the logistical challenges of doing that with 2,000 community health workers located throughout relatively remote provinces and areas of the country. So thank you for sharing that. We're going to now loop back to some of our earlier speakers with a few questions. We've had a very active chat. Thank you all for contributing so many thoughtful questions, comments, suggestions. We are going to save this chat history and we will use it. So please keep your questions and comments coming. We're going to turn back with a question for Dr. Siv now. And Dr. Siv, Shri from our participants has asked if you could provide a little bit more information about how Cambodia is using community-based approaches to serving the needs of forest goers. And I think Cambodia has a lot to share with other countries in the region in terms of multi-sectoral approaches, collaboration between the Ministry of Health and Ministry of Environment in terms of community-based outreach with forest goers. Can you please share more of your experience with us?
Yes, actually we have a strong community network in the country. But however, during the COVID-19 pandemic, there is a quite challenge of the service that's provided by the community, especially to the forest grower. We, as I told you, we has been identified on time the reassessment, and we know how to do the mitigation plan for the community network to continue their service at the community. So in the reality, we have been told you that we are keep testing, increasing 55% compared to 2019. This is a great community that has been dealt with. because we have a good guidance for them to how to keep safe for them. And in terms of the challenge of increasing some activity in the forest due to the increasing activity of the forest grower, we has been a strong system to identify real time where is the hotspot that malaria is happening in the forest. And by using this system, we have ability to create create a new hotspot services that around the country, especially where the PS burden has been happened. As an example, I can give you an example that one of the province has been the increasing PF that we found out recently, and we has been note that this is due to some hotspot has been increasing. So we identify the hotspot and we set the community services on time at the hotspot. And at the hotspot, we have been provide malaria services with the PPE protection that the community network can provide. The services cannot be free of a transmission of COVID-19. And also we provide the forest pack for the forest goer when they go to the forest in order to make sure that they can protect themselves during working in the forest. And beside on that, we have set a screening at the exit and also entry point at the hotspot. So we screen everybody that pass going and out in the hotspot area in order to make sure that no parasite has been carried out to the village in order to protect the transmission in the village. Thank you.
Very interesting. Thank you for sharing that, Dr. Sev. Dr. Afsana, we would like to turn back to you with a question from one of our participants. Mr. Tuan Nguyen has asked, how has COVID-19 containment measures, including the lockdown and social distancing protocols, impacted community level testing for malaria? And can you share with us more insight in terms of whether the restrictions are affecting the community health workers more, or whether they are affecting the individuals and communities at risk more, or whether it's a mixture of both, and what the impact is? Dr. Afsana, over to you.
I couldn't hear you the last question. The first one is like how the COVID situation is affecting on the community health workers. And second one was what?
So in particular, how the social distancing and the lockdown measures are impacting community level testing, how they are impacting community health workers movement and organization of community level services, how they are impacting the community's ability to access those services. So looking at the question from both angles, but in general, how are the lockdown and other restrictions impacting your testing at community level?
Okay. Okay. So, okay, thank you. So we are actually COVID situation with the community health everywhere. This is you have to admit it because even all the health workers, even the doctors, the nurses, everyone is afraid of going out, and because this is a novel virus and nobody knows that what are actually the symptoms and what are the precautions they have to make. So in the field level, they are the health workers. They are not always the medical doctors or nurses. They are not. They are only the health workers who are getting the training from us, and they are actually treating those people. So it was in our lockdown, Bangladesh started from 26th March. So from that day till 1 month, everything was shut down. Everything was locked down. So nothing was there. Nothing is moving there. So in that situation, the case actually only for the COVID situation, the case decreased. We could not send any healthcare workers to go to the field. And for that reason, there was no testing, there was no case identification, it happened. But after that, the situation, it comes a little bit like normalized. We from the central level, we actually communicated them with the healthcare workers, because from the field level, our community clinics were there. There was civil surgeon who is the head of one district. We provided them personal protective equipments, PPE. We gave them some BCC materials. We trained them on COVID, the IPC, like how you wash your hand, how you maintain social distancing, how you use the sanitizer, how you use face mask while you are going to visit the households. So these are trained. Like after April, from May, we try to train all those health workers. That even with the with Uthan Boitok, what we are calling that, if in a meeting in the yard, small yard in front of your house, so they had to maintain social distancing. They shouldn't shake hands, but they can wear gloves, and how to use it, how to use the gloves. So we actually prepared all those healthcare providers before we send them to the field again. So it was a huge work done online also. Actually, we are doing it online. The training was online, and we are also cannot move there. So this gives us a huge pressure both on us, the central level, and also with the field level people. But hopefully, and by the grace of Almighty, now all the field workers, they are now able, they know how to deal with in the COVID situation, how to deal with the malaria situation. And this is how we are now detecting more cases, and the tests are also like increases now, and we provide them the RDTs and all the necessary things we are having now. Thank you.
Thank you so much, Dr. Afsana. Very helpful additional insight into your experience in Bangladesh. We are running short on time, but we would like to invite Dr. Masu from Medical Action Myanmar to share a few thoughts about Medical Action Myanmar's experience implementing community-based elimination and other integrated health services along the border areas, in particular in Myanmar, given that that is a specific focus of today's event. Dr. Masu, welcome, and please share a few remarks with us.
Okay, thank you. And thank you, Josh, and also the APMEN team for organizing this and inviting me. So it's a great honor to be here. Yeah, so as we all know, MEM has 2,000 volunteers, mostly in the border area, conflict affected area. So in addition to malaria, we integrated the services. We call it basic healthcare services. They are mainly the most common illnesses that we train a volunteer to be able to treat the most common minor illnesses, and then also to be able to identify and refer when something went wrong and they need the treatment at the facility level. So based on I think during the COVID period, I have I think 2 slides to prepare, because of the misunderstanding, I prepared at the last minute. So I think probably that's not, ready to share, here. So, but based on our experience that, we saw that the performance, the RED testing uptake, and as well as the basic healthcare utilization, the BAC consultation, we call it consultations, has not reduced, during the COVID period. And we saw the opposite, it has increased, in our, at least in our villages coverage, Sorry, yeah, okay, thank you. So as you can see that is from exactly the same volunteer, the same villages from Blawa Township, the 200 volunteers. So the area has not changed, the population coverage has not changed. And then we can see in the 2 columns, the first one is about testing and the second one is basic healthcare consultation. So it has not reduced. And also even on the reverse, and the malaria testing, like we are very committed in the beginning of the year, because we want to do mass screening, like a targeted screening to the very high endemic villages that has like more than 10% early positive rate, because there is always outbreak in these villages every year in the rainy season. So we want to prevent this. So we want to do this mass screening just before the rainy season. So when this like COVID and restriction, but we are determined to do this, make it happen despite the COVID, and then we achieve. So as you can see here, the service utilization has not reduced. And I think the lesson learned from next slide, please. From here, I mean, based on our experience, it's like the first one is about proactive planning. We know that this is coming, because in other countries, we know that COVID is happening in other countries. So what are we going to do in this country? What are we going to do in this scenario when there is no local transmission, where there is no local transmission, when there is death? So based on the different scenarios, we develop action plan. So proactive planning. Proactive planning includes even before, even in January, we are procuring a lot of drugs to be able to supply. So if we cannot go there, then we have to make sure that we ask a volunteer to continue the services, to protect themselves, and also to provide the services, because they will be the only provider in the community at the time if everything is blocked. So we procure a lot of drugs, and we send to make sure that, like previously 3-month buffer stock at the community level, now we send 6-month, 8-month stocks, depending on that. So that kind of contingency plan works. And also, let's move to the third point, which is flexible operational strategy. So we are very flexible. We work in a very, like the situation is changing dynamic. You cannot stick to one scenario, and therefore, whenever the field team think that they need support, they want to change the strategy, they can communicate channel is open, and they can directly contact, and we switch. We want to buy the drug, we need to buy the PPE and masks. I think we also should thank to the very flexible donor, like private donor, because on top of the institutional donor like Global Fund, we also have some other private donors. For these requests, we just need a Skype call. We explain the situation, they are very understanding, and having a flexible operational strategy and opening the communication channel, these are also the key. And also using lessons learned from other emergency contexts, and adjusting the strategy. What I mean by that is we have been working in a conflict affected area. So, and also we have worked in a disaster situation. So we have learned a lot, these contexts. So for example, when you work in a conflict, in a war zone, you don't know when you will be able to visit this village or this volunteer next time. You can visit this month, this week, but next week, this is blocked. So we are always have a contingency plan. We have the different strategy method. Okay, we will come to you, and then next week or next month, this week, if we don't come until third week, you come to this year. Or we will send with the public transport or anything, something like that. So that a lot of lessons learned that we use, yeah?
Thank you so much, Masu. This is really, really wonderful insight. And I'm so glad that we were able to share your slides. We will make them available through the chat.
Yeah.
Unfortunately, we are out of time. So if you will forgive me.
Yeah.
Thank you so much, Dr. Masu. And we will come back to our overall group of participants and 3 speakers. We are running very short of time, and I can see that we are losing a few of our participants. So I would like to acknowledge the wonderful data and case studies that have been shared in both of our sessions by our speakers, the very thoughtful questions from all of you participants, and I am sure there are more among our observers who have been with us today as well. It has been a very rich learning experience today. Clearly, as we always conclude with every APMEN meeting, we need more time to digest and to share these good ideas and emerging best practices. And certainly today's event will spring us forward, and we will come back to all of you with more thoughts about how we can keep this amazing work that you are all doing at the community level going, and most importantly, how we can continue to share best practices and learnings across the region, which is one of many strengths of the APMEN network. I would just like to, before we leave, ask everyone one last question, which we're going to ask you to please respond to in the chat. Please help us by sending us your thoughts in the chat about one key message that you would like APMEN and APOMA to deliver to senior officials this week with respect to community engagement. Clearly, multiple speakers have demonstrated the value of community engagement, not only in contributing to elimination, but also other integrated primary health services and COVID-19 containment efforts. So please help us draw attention to the data and the case studies that you have presented and the thoughtful questions and learnings that have evolved through today's event. We're looking for one key message for senior officials. Please share your ideas with us in the chat. And with that, I thank you all, and I turn it back over to Jos to wrap us up.
Thank you so much, Jocelyn, and I think everybody agrees you did a wonderful job and energized us throughout the last 2 hours. And I also want to thank, of course, everybody else for staying. Some of you have been online for 4 hours, and I just have to admit that we have one more poll to fill out. It takes only 1 minute, so before you switch off, please fill out the poll that will appear in a second, because we want to know a little bit how this meeting was for you. We're asking in one go, so for both meetings. So please give us another minute of your time. And otherwise, we are looking forward to seeing many of you in the next days. This was just the beginning, day 1 of Malaria Week. And so hopefully you can join some of our sessions during the rest of the week. Tomorrow we have an interesting session on surveillance and timely reporting. We have on financing, on innovation, and then the SOM on Friday, as Jocelyn highlighted. So hopefully many of you join our other sessions. And if you have time, do what Jocelyn asked for. Let us know what are the key messages we should actually bring into the SOM. We try to distill some joint messages from all the qualitative comments and from the discussions we heard today. So thank you very much for all of you. Have a good day or have a good lunch, depends on where you're calling in from. And some of you may be having even a good night. And see you hopefully tomorrow. Thank you all.